respected dignitaries, esteemed faculty, and dear participants. On behalf of the Department of Emergency Medicine at Bhaikaka University, it is my privilege to warmly welcome you all to this pre-conference workshop. I would like to begin with a timeless Sanskrit phrase described in the Bhagavad Gita, Yogaha Karmasu Kaushalam. That is, excellence in action is the true yoga. In emergency medicine, this principle becomes our everyday reality. In moments of uncertainty and urgency, it is not just our knowledge, but the presence of mind, teamwork, and compassion that defines outcomes. Each second carries responsibility and each action has the potential to save a life. Very much in line to the core of our conference, Pran Rakshanam Paramam Dharmaha. Today's workshop is more than just an academic gathering. It is a shared commitment to sharpen our skills, deepen our understanding, and inspire one another to strive for excellence. As we begin this meaningful journey together, let's start by invoking knowledge and wisdom through the traditional lamp lighting ceremony, a symbol of dispelling darkness and igniting the light of learning. We are truly honored to have with us our distinguished dignitaries, Dr. Abhay Dharamsi Sir, Provost, Bhaikaka University, Dr. Jyoti Tiwari Ma'am, Registrar, Bhaikaka University, Dr. Swapnil Agrawal Sir, Dean, Pramukh Swami Medical College, Dr. Jitesh Desai Sir, Medical Superintendent, Dr. Darshan Shah Sir, Organizing Chairperson, Kemkon, Dr. Hemlata Kamath Ma'am, In Charge, Skill Lab. I request all the dignitaries to please take your seat at the dais. Thank you. Your presence inspires us and strengthens this academic endeavor. I now request our respected dignitaries to kindly come forward for the lamp lighting ceremony. For the smooth conduction of our program, I request all the participants to turn their mobile phones to silent mode. Thank you. I would now request everyone to join us in our morning prayer. Thank you, esteemed dignitaries. We are deeply honored to have you with us today. And as a token of our love and respect, we would like to felicitate our distinguished guests. May I request Dr. Sapna Gupta ma'am to felicitate Dr. Abhay Dharamsi sir. May I request Dr. Alpa ma'am to felicitate Dr. Jyoti Tiwari ma'am. May I request Dr. Sanjay Shah sir to felicitate Dr. Swapnil Agrawal sir. I request Dr. Sunil Chhajwani sir to felicitate Dr. Jitesh Desai sir. May I request Dr. Harsha Makwana ma'am to felicitate Dr. Hemlata Kamath ma'am. I request Dr. Jishmi Shah ma'am to felicitate Dr. Darshan sir. Thank you. Now, with all the spiritual enlightenment and all the preparatory adrenaline rush that we are having, we have planned a very compact and crisp academic bonanza for all our participants. Our faculty has worked really hard for this, and I really hope that you guys enjoy Kemkon. And this conference is just the beginning. There's a lot more to come. Without spending more time, I would like to request our workshop in charges to begin their workshops. And if any of our dignitaries agrees to bless us on this occasion.
On behalf of the whole institution, I welcome all of you for this workshop, and I believe most of you are there for tomorrow's conference also. I hope the to my knowledge, there are 2 different workshops for the day, and we believe that there is a learning on both the sides from the workshop. You will also move around the skill lab, as well as you will also see the Department of Medical Education, and I would sincerely request all of you to give in your suggestions for further improvement in our skill lab as well as the Department of Emergency Medicine. So once again, I welcome you all on behalf of the whole institute.
Thank you, sir. I would like to request Dr. Abhay Dharamsi, sir, to speak few words of blessings.
Good morning to all of you. At the outset, I would like to congratulate the Department of Emergency Medicine for organizing this Kemkon. I also extend a warm welcome to all the delegates and the respected doctors who have come here from different parts of Gujarat to attend this pre-conference workshop that is held today, followed with a scientific conference tomorrow. I was just trying to wonder how important role you play when a patient is meeting with an accident and they land up in the emergency area. You are the real warriors, because that is the golden time where you have to take different kinds of action without knowing the history of the patient, maybe a child, maybe an adult, maybe a geriatric patient, and those 25-30 minutes is what is very important for all of you before you pass them to the specialized doctors. I appreciate all of you for all the hard work. There's a striking difference between a medical profession and any other profession for that matter. And the difference is, you're all trained to work on a living body, whereas an engineer, for example, if they have to repair a car, they have to make the car stop and then repair the car. Now that is the big difference, and I think all of you need a loud applaud for whatever you have been doing. I am sure you will have a lot of exchanges between yourself. You will build up your network, learn a lot of good things, because such workshops are meant to train you to hone your skills and make you more perfect, right? So all the best and have a pleasant time. Thank you.
Thank you, sir, for the amazing kickstart. I would like to request Dr. Jitesh, sir, for a few words.
Good morning, everybody, and welcome to the our institution. As our sir, Dr. Dharamshi said, one of the most thankless department is emergency medicines. Because if everything goes right, subsequently in surgery, orthopedics, medicine, then nobody remembers emergency medicine. And if something goes wrong, the problem was with the emergency medicine. If they had done so, we could have saved. So you are the real warriors who are always staying behind the screen, but still one can't do it. So congratulations to our team for organizing such a wonderful, and I think first of its kind Kemkon, where emergency medicine is hosting a conference. I hope you'll have a good time, and your visit over this weekend will be worth. All the best. Thank you.
Thank you, sir. Indirectly, sir just claimed our clan as the Batman group. So we are there when no one sees us, and we finish our jobs. Thank you, sir. Ma'am. With all your blessings and all your enthusiasm, let's start with our workshops. We have a time-bound schedule and just a few instructions before we begin our workshops. The delegates and faculty for hands-on focus workshop are supposed to stay back in the skill lab, and the delegates and faculty for hands-on procedures workshop will have to head to the anatomy department. We'll go together. Thank you.
Good morning, everyone. So we'll start with the knobology. I personally feel it's a very important chapter to start ultrasound, because if you don't follow the rules of knobology, you will not get a better result. Okay, so to what is knobology? It is the understanding of ultrasound machine controls and to optimize the image quality. A bad image leads to a bad diagnosis, and a good image saves the time in the critical situation. Machines differ, but the core principle always remain the same. The machine components. So the main machine components are transducer, probes, control panel, trackball. In terms of the probes, we commonly use linear probe for high frequency and shallow structures, curvilinear probe for low frequency and deep structures, and phased array probe for low frequency, small footprint. And presets are always necessary to start an exam, because presets are the baseline of a scan. So you cannot start an abdomen examination in the cardiac preset and vice versa. So always before starting any scan, you need to select the preset first. So this is the linear probe, which is the high frequency probe, then the curvilinear probe, and the phased array probe. In market now we are also getting a all-purpose common probe, which can be used for all purpose, but it has a limited resolution. So application presets. In all machines, common applications are there. You need to select it whether you want to do a cardiac examination, abdomen, OBGY, lung, or EFAST. So the big three controls are: first is your depth, your field of view. Second is your gain, your brightness, and focus, your sharpness. In each and every scan, you need to adjust this. If you are doing, if you want to see pancreas, you need to again change all three settings. If you are going to kidney, you need to change some settings. You are going to urinary bladder, you also need to change it again. A minor tweaking is always necessary to get the optimum image. So in this image, you can see the depth control. You can easily control the depth, and why the depth is necessary, because if you are seeing a kidney which is just 2 centimeter below and you are seeing at the 8 centimeter depth, your machine will automatically change the frequency, focus point, and all other settings according to that. If you just focus on the kidney, the machine will automatically change the focus point, the frequency accordingly, and will give you better results. In gain, it amplifies the returning echo signal to make the image brighter and darker. And in overall gain, it turns up the brightness for the entire screen. You can see in the superior images that it is it has more gain, and in the below image it has less gain. You can easily see the difference in the images, and this all images are of a focus portable machine only. TGC. So TGC concept starts in early old age machines, in which we can easily change the parameters according to our needs. So in left you can see that laser so you can easily see that this settings is at off, so you cannot see this part. In same, it is at the normal level, so you can see a whole image. Why it is necessary? Because sometimes you don't want to see this structure, and you sometimes you don't want to this structure, so you can change the TGC and improve the image quality. So focal zone. So this is a very important part of ultrasound machine, because what happens is if you select a focal depth at the same level, you want to see the frequency at converge in that region. So if the frequencies are converged in that specific region, you will get a better resolution and better image quality. In some machines, they don't provide focal point. In some machines, they do provide. But if we stick to one focal point, it will drastically improve the frame rate, the frequency, and the resolution of the machine. So in operating mode, we have B mode, which is the standard 2D grayscale mode for real-time imaging. We have M mode for motion mode, a single line ultrasound for overtime use, specifically used for lung sliding, fetal heart rate, and cardiac valve motion. So this is a image of a portable ultrasound, in which you need to select the color mode, M mode, 2D mode, pulse Doppler mode, and continuous wave Doppler according to your needs. In Doppler mode, it detects the direction of velocity of blood flow. It is BART, blue away, and red towards the probe. Color indicates the direction related to the probe. It is not that red color is the artery and blue color is vein always. It is always in the direction of the probe. And in pulse wave, it measures the exact velocity of a flow at a specific point. So to optimize depth, select the probe, adjust the depth. While selecting the probe, it is very much necessary to use both the probes, curvilinear and linear, because if you see bowels in the curvilinear probe, you will miss certain important findings. Also in terms of fast, I always advise to check with the linear probe, because some minor early fluid can be missed with the curvilinear probe. And also, if you are selecting the curvilinear probe and you are seeing at a very shallow depth, you need to change the frequency to a higher settings to better get the for optimizing the image. So some machines uses the frequency word, some machines uses the resolution, penetration, and general settings. So in common, GE machine uses the frequency. So there are 3 settings in the curvilinear probe, whether you want to use it in 3 megahertz, whether you want to use it in 4 or 5. If you want to see in penetration, you need to select the 3 megahertz. If you want to see in resolution, then you need to select the 5 megahertz. Same things applies to the linear probe. Linear probes are routinely 12L, so the frequency ranges between 9 to 12, and in the curvilinear it ranges from 1 to 5 or 1 to 6 depending on the probe. So adjusting the depth, then adjust the gain, apply TGC. So routinely now we always click a auto button for TGC. So now newer machines have the auto button. You just click a auto button, it will automatically adjust the TGC, and you need to set focus if available. So workflow and documentation. I always recommend to freeze the machine while you are taking the image, and also when you are not using the machine, always freeze the machine, because you need to care for the machine. If you don't care for the machine, after 1 or 2 years, the machine will resolution of the machine will degrade drastically. So always after using the machine, freeze the machine. Then you need to, for documentation, you need to take a sine loop or measure the distances and always save the image. So in next 5 years, if you perform ultrasound, you report it and you don't have an image for that, you cannot prove it. So right now in emergency settings, yes, we can ignore that part because we need to do other things also. But if it is not emergency settings and you do have time, you always document the patient and save the patient images. In summary, pick the right probe, find the target, adjust the depth, adjust gain, focus, freeze, measure, and save. Thank you.
We will have 5 stations. So before that we will have introductory lectures. Yes, sir. We will have introductory lectures of the 10 to 15 minutes of all the stations. Followed by that, we will go to the respective stations. So the next one will be the Dr. Arshid Mehta sir.
Good morning, everyone. First of all, thanks to the Kemkon team for having such a wonderful sessions and academic fiesta, because it is very important to learn and then execute, right? So these 2 days you will be learning a lot of things, and make sure that whatever you learn, please execute. When I was studying, there was a quote that if you don't know how to swim, then you go to a sea, then you will not go inside. And if you know how to swim, but if you don't go to the sea, then also you will not swim. So here you have to, first thing, that know knowledge, and then when you go to the patients, execute. So both the things are important equally, right? So to begin the first session of the focus is the E-fast. That is one of the most common things that you do being an emergency physician in your ED. Because previously there was a stethoscope, and now what we say is that each probe is your new stethoscope, right? So stethoscope definition has changed from the routine stethoscope to your probe, because it gives a lot of idea that stethoscope may not be able to give. So in E-fast, basically it's an extended focused assessment with sonography in trauma. So this is a full form. So any patient comes with trauma, it is ideally in the primary survey you have to do the E-fast. It is very easy to do, and in this session or on practice we will see how to do E-fast. But just to give a brief idea, it is the extended. Initially it was fast. When I was studying 2010, it was just a fast focus assessment with sonography in trauma, but later on E was added, and now it has been E-fast. So probe generally we use is the curvilinear probe, and it is very easy to use that. So 3 questions it will answer. First question, is there a fluid in abdomen? Because we see in abdomen. Is there a fluid in pericardium? Because we see pericardium also. And lastly, is there any evidence of pneumothorax or hemothorax? So when you complete your E-fast, you have to have these 3 answers: pericardium, peritoneum, and pleural space. So it gives you the okay. So it's a pathway that if you have a primary survey and chest is something doubtful, then you do E-fast and see whether there is any fluid in the pleural fluid space or not. And if you have abdominal assessment and there is something abnormal, then you can check the peritoneum and you can see whether is there any fluid or not. So these are the spaces. First we start with right upper quadrant, then we go to left upper quadrant, then down, then pericardium, and then bilateral chest. So initially it was this 4, but later extended, the chest part was added. So first window is your right upper quadrant. So when we see, you have these structures to be seen, superficial to deep. Alright. So skin and superficial tissues, liver, kidney, bowel, and lungs can also be seen. So in stations, it will be very easy for you to recognize these structures. So what here we have abnormality is here, that is the liver and kidney pouch, that is called as Morrison's pouch. If there is any fluid, then it says that okay, there is something abnormal in that. Then second window would be the left side next. Okay, so in left side you have spleen, kidney, and rest of the things are similar. So in right side you have liver and kidney, and on the left side you have spleen and kidney. And the pouch between these two structures, if there is any black shadow, that means there is some fluid collection. Okay. If you have not seen this kind of patients first, so if any patient comes with CLD, chronic liver disease, and patient is having ascites, in that patients, if you do such things, then you will have a free fluid. But that is not blood. In trauma, it is blood. In CLD, in chronic liver disease patient, it is not blood. So in sonography, you cannot differentiate whether it is blood or some other fluid. But you can differentiate that there is something, some fluid in this kind of spaces. So later we'll see that these are the caveats of this sonography. Next. Then the suprapubic, where you have a bladder and perivesical fluid collection. So in male and in female, the structures are different. So you have to recognize the structures as per the patient's gender. Okay, next. So here it is the free fluid. So this is structure, and the black shadow. Black shadow is generally a free fluid, but we don't know whether it is blood or any kind of other fluids. Okay, next. Subcostal view. So when you put in the subcostal view, you have first liver, and then you can see the beating heart, and on the both sides you have lungs to see. So you have to see the beating heart and the surrounding of the beating heart. If it is a black shadow, that means there is some kind of pericardial fluid. Next. So cardiac pitfalls, this is true pathology. So surrounding black shadow, that means it is fluid. Sometimes this kind of shadow you can see, but it is not a pericardial fluid, it is a pleural fluid. And in all structures, you have a fat stranding surrounding the organs like kidneys and heart. So this fat is also the black shadow. So you may miss, or you are getting confused whether it is a free fluid or some kind of fat stranding. So it is called as pericardial fat pad sign. If it is surrounding the kidney, then you can say it is the perinephric fat pad sign. So fat pads are also seen as not jet black, but certainly hypoechoic than the organ itself. So you may get confused whether it is a free fluid or a fat pad sign. So as per the history, you have to check what it could be. Next. So thoracic. In thoracic, in the second half, we have a lung ultrasound. So we'll get the details in that. But in lungs, generally what we see is the pneumothorax. And for pneumothorax, two signs are very specific. One is lung sliding sign, and second one is the lung point. So lung sliding sign, it is also known as barcode sign. So if you put M mode, that we'll see in the stations. If you put M mode and if lung sliding is present, then you will have a barcode, right? And if lung sliding is absent, then you have a seashore sign also. That also we can see in the station. So seashore sign, barcode sign are same. Whether you can say a seashore sign. So here it is a sea and it's a shore. So if seashore sign is present, that means it is normal. If seashore sign is absent, that means it is a barcode sign. All lines like this, that means lung sliding is absent. Lung is not moving. Lung moves, then only this kind of pattern will come. If lung doesn't move, then this kind of pattern will not come, and that will come as a barcode sign. So barcode sign is positive for pneumothorax. Seashore sign is negative for pneumothorax. So you have to make sure that what kind it is. Okay, so be clear in your mind what you want to see. If you see this kind of pattern, that means lung is normal. Okay, if you don't see this kind of pattern, just lines like this, that means there are chances that patient may have pneumothorax. Alright, next. So that is the lung point. Here lung sliding is present, here lung sliding is absent. That means from here patient is having pneumothorax on this side. From here patient is having normal lung. Alright, next. So if 100% air, that means pneumothorax. 98% air with normal lung, 95% of air, that means interstitial lung, you have a comets. 10% of air, that means some kind of pneumonia type of picture, consolidation, and 100% fluid, that means pleural effusion. So pleural effusion doesn't mean hemothorax. As we discussed that ultrasound can say there is a fluid inside, but what kind of fluid, that we don't know. Right? It can be pleural effusion, right, serous or exudates, or it can be blood. So depending upon the history, now in patients of trauma, if we see this kind of picture, then suspicious is a higher side of hemothorax. But if patient without any kind of trauma history, if we see this kind of picture, then it's kind of pleural effusion, that is not because of trauma. Okay, next. So just in nutshell, right upper quadrant, that is perihepatic region. Longitudinal we check just at the lower right ribs. What we see is Morrison's pouch and subdiaphragmatic area. On the left side similar, but splenorenal pouch and subdiaphragmatic area. Here you need a deep inspiration. So ask patient to inspire, deep inspiration, then only, because spleen is slightly on higher side than the liver. So you have to ask patient to slightly deep inspiration so that spleen comes down and you can see this area very clearly. Then in pelvic or suprapelvic region, you have to see transverse as well as longitudinal, and you can see retrovesical pouch and pouch of Douglas in females. In cardiac, subcostal view, angle to the left shoulder. So if you put here, then it should be on the towards the left shoulder. There you can see acoustic window near liver as well as pericardial space. Next. So the role is it requires a slight more amount of blood than the usual. So CT scan would be higher in sensitivity to find out less amount of blood, but in USG you need some kind of high amount of blood. Next. So pitfalls, bowel fluid can also mimic like a free fluid. The empty bladder will not give you a good idea of perivesical space because the full bladder gives a good acoustic window. Poor probe contact with the patient also will not give you a good kind of the image. And clotted blood. So if blood is there, fresh blood, then it will show as black. But if blood is clotted, then it will see as white. Right. So it is very tricky to differentiate. Where you can see the clotted blood mainly. So when you do 2D echo and if patient is having white shadow within the chambers, then you can say it is a clotted blood. So if you come across any patient with MI, entry wall MI, and wall is not moving properly, then you may see or perceive that there is kind of white shadow within the chambers, then it could be blood. But in trauma generally we don't see much because it's a very fresh and acute trauma. So it is very difficult to see a clotted blood within this, but if it is kind of white shadow within the blood's black structure, then it could be clotted blood. Next. So advantages of this kind of sonography: rapid and non-invasive, and it can be done bedside. Highly repeatable, so you can do every 10 minutes, and high sensitive and specific if the right question is asked. So you have to ask 3 questions when you start EFAST. Limitations: misses small volumes, so there is a loophole. Misses hollow viscous or solid organ tear without fluid if there is no fluid, but still injury can be there. But in those cases, patient would be stable hemodynamically. And can I send the patient home? So EFAST is a triage tool, not a discharge tool. So it will help you to do triage, but the discharge you cannot predict out of this. Next. So where is the what is this? What is this? And there is a black. Right. Now kidney for sure. Right. If it is on the left side, then this is spleen. Right. And there is a black shadow coming up. So that is a free fluid. Okay, next. Right? Okay. So kidney or liver, this is liver and surrounding. But this is may not be the blood. Right? Because this is kind of ascites that you can see. But just to give you an idea that how a free fluid will look like, then this is a black shadow surrounding the structure. Okay, next. See. This is if the left side, then spleen, the right side, then liver, kidney, and the free fluid. Again, this much amount of free fluid, it is very difficult to get in trauma patients. So, but just to give you an idea. Next. So EFAST doesn't diagnose the exact injury. We don't know what kind of exact injury it is, but we can say there is a free fluid in trauma. And in trauma it is most probably blood, so we need to do something. It categorizes the immediate threat to life and dictating whether the patient's next destination should be in OR or CT scan. Alright, so if patient is stable, minimal fluid, then you go for CT scan. If patient is hemodynamically unstable with lot of amount of blood, then obviously patient should go to OR immediately. Alright, so you will have a better idea in stations. Alright, okay. Thank you.
So the next lesson will be on the airway by your moderator, Dr. Mukil Singh.
Good morning, everyone. My station is a airway. We will do practical on a station, but in that 10-minute short lecture, I will give you all sono anatomy and different part of theory. Myself, first of all, thank you so much, Kemkon whole team, for giving me such an opportunity. And I myself, Dr. Mittal Sindhu, I am Associate Professor in Sumandip Medical College and Head of the Department. So before starting airway POCUS, I want to ask a student, have you done POCUS of airway in your practice? Any of one, tried once? Just raise your hand. Nobody? So after this lecture, you will try to do. We are not using POCUS every day for the airway because visually we insert the ET, that is a gold standard, but there are certain conditions where the patient anatomy is not favorable, where patient had an injury, where patient has a tumor. In that situation, the POCUS may help. There is some numbers कि in emergency intubation failed intubation rate is every 1 from every 300, and it increases mortality by 30 times. And if you confirm ET tube with the POCUS, it is time taken, it is less than 12 seconds, and it has more than 90% of sensitivity. So here you have to remember 3 things. Always use linear probe because better visualization. You can use curvy linear when their patient is much obese, but start with the linear probe. The marker should be on the right side, and always do transverse view first. Okay, so remember these 3 things. So first I'm going to talk about sono anatomy. So if you know anatomy well, you can measure the all distances, you can calculate, and you can confirm ET, and various application of the airway POCUS you can perform. But first you have to more precisely do sono anatomy. So we all know in the anatomy there is a 3 main thing: hyoid bone, thyroid cartilage, cricoid cartilage. In between there is a thyrohyoid membrane and cricothyroid membrane. So you should know about the anatomy. We will see how it shows in the POCUS. But here most important thing is CTM, the cricothyroid membrane, because it helps in needle cricothyrotomy. If you know the sono anatomy, you can identify, you can mark the point, and you can go for the needle cricothyrotomy. So this is the level 1. It is hyoid POCUS view. The hyoid will look like bright hyperechoic arc and a strong posterior shadow below. So you can measure the HMD also, hyomental distance. We will see later on. But you can see the picture, so you can easily identify on station. Then the pre-epiglottic space. The third one is the thyroid cartilage. Now you have seen that vocal cord is a arc-like shadow, but the thyroid cartilage is a V shape. So it is inverted triangle. So it is a steep-sided volcano. You have to identify. Then and then you can focus on the normal patient. So it is a steep-sided volcano. You can see. Here I am showing you thyroid cartilage, but at a upper view. In mid-thyroid cartilage, it is less steepy-sided volcano, like this picture. And in lower thyroid cartilage, it is more steepy, like the image. Level 4 is a thyrohyoid membrane. So to identify cricothyroid membrane, you have to focus on thyroid cartilage and cricoid cartilage. That is called Taka technique. So both the thyroid shadow is also having air column, cricoid shadow is also having air column. Between these two, there is cricothyroid membrane. That technique is called Taka technique. So here the anatomy. So we have seen the transverse view. Now this is longitudinal view. If you initially see, it is look like similar, but you can identify like this. The tracheal ring is pearl of ring like pearls like structure, and this angular portion is a thyroid cartilage. So between these two, there is a cricoid cartilage, and this is cricoid. This is cricoid cartilage, and between these two, there is a cricothyroid membrane. So we have to identify these things. So first is the transverse view, now longitudinal view. This anatomy is more deep. So what is the uses in emergency and critical area? First we can predict the airway size and we can calculate the ETT size number. Second one is we can predict the difficult laryngoscopy. The third one is ET confirmation. Fourth one is assisting with the placement of surgical airway. The fifth one is predicting post-extubation stridor or failure. And sixth one is evaluation of epiglottitis. So to use this all, we have to master the sonoanatomy. If you can identify the structure, you can measure that structure and distance, then you can apply this all things in your daily practice. So I know you never use, because in normal anatomy it doesn't much help. But what if, because anesthetist and emergency physician called when there is a difficult intubation, when nobody can intubate, they called you. So you should be one step ahead of them. So you should know what is POCUS airway, how sonoanatomy, how I can measure, how can I predict difficult airway, how I can manage the when patient is cannot intubate and cannot ventilate scenario. So specialty in obesity, cervical trauma, neck mass, when patient is having trismus, when patient is having tumor and burns, you can use that modality. This is airway size prediction. We know we all have a chart of ET size. In adult, we are using 8 and 8.5 in male and 7 and 7.5 in female. But if you want to predict the ET size, in the subglottic view, you can measure the distance, and with that distance, you can measure the size of ET. This is ET confirmation method. Which one is ET? In the subglottic area, the green was endotracheal ET tube. Esophagus is a bit lateral. So you can confirm ETT with the POCUS. And it is evidence based. It takes less than 12 seconds.
very easy if you have ये इसके परपेंडिकुलर 90 डिग्री पे वुड ऐसा है और स्ट्रक्चर इस तरह वर्टिकल
करेक्ट कर। अब ये हो गया। अब ये जो पकड़ा था ना, ये दोनों फिंगर में इसको छोड़ दो, इसको छोड़ दो और ये मिडिल फिंगर से इसको खींचो, बस खींचो डन। इसको टाइट करो, हाथ छोड़ के वापस खींच के टाइट करो। यू गॉट इट? हाँ बराबर टाइट करो। अब टाइट करने के टाइट जब आप कर रहे हो तो डायरेक्शन इंपॉर्टेंट है, ये ऐसे ही डायरेक्शन में टाइट। अभी आपको बताऊँ मैं, पहले वो आपको
खबर ऊपर से मुझे
समझ। अगर इसको हम जैसे गूगल से कंफर्म किया, रिमूव द सीलिंग और क्या आएगा अभी गश ऑफ एयर। इफ यू आर नॉट रिमूव मच ऑफ राइट, गश ऑफ एयर आया इसका मतलब क्या होगा, यू आर कंफर्म दैट यू आर इन द टोटल स्पेस। ओके, एंड देन क्या करेंगे, बाय द टाइम वी आर प्रिपेयरिंग फॉर द थिंग दैट sorry the story
or there is a yes, there is a then you will not see like that body. Then sternum, then fever, distal fever, uterus. These are the most common signs. We will see how swelling, whatever drugs, fluids you are giving, that should not extravasate. Compartment syndrome is a contraindication, it is also a complication. Okay? Now selecting the size of the needle, we should show you there.
ના 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 કોઈ એન્ડોકાર્ડિયમ જે છે એ એન્ડોકાર્ડિયમનું તમે એક આખું મેઝરમેન્ટ લો બરાબર. અહીંયા આગળથી તમે એન્ડોકાર્ડિયમને ઇવેલ્યુએટ કરો એટલે શું થાય કે એલવીની જે છે લેફ્ટ વેન્ટ્રિકલ એની કેવિટી એ સિસ્ટોલમાં કેટલું વોલ્યુમ આવે છે અને ડાયસ્ટોલમાં કેટલું વોલ્યુમ આવે છે બરાબર, એ બંને કેલ્ક્યુલેટ કરીએ on the basis of difference between the LV cavity systole and diastole. એના બેસિસ ઉપર you can calculate the ejection fraction, right? બરાબર. તો હવે આ જે છે આપણે આ ઇમેજને ફ્રીઝ કરી દઈએ ધારો કે. Now this is probably systole બરાબર. હવે એની અંદર તમે મેઝરમેન્ટ પછી ટ્રેસ ક્યાંથી થશે?
તો ત્યાંથી સેટ કરી.
So now what we are trying to trace is the endocardium of the heart at the systole. Okay, save થઈ ગયું બરાબર. હવે આ ડાયસ્ટોલ માં આવ્યું.
સો આ એક બેઝિક આખા સહી તમને અહીંયાથી એમ કરો તો એ આખા સ્પેક્ટ્રમની અંદર કેટલી મૂવમેન્ટ્સ થઈ રહી છે સો એ તમને બતાવે છે. તો આઈ થિંક લંગના ફર્સ્ટ ઓલ્સો તો સીસી શોર્ટ્સ એન્ડ
ये ट्रेकियल रिंग्स नहीं है, हाँ? ये ट्रेकियल रिंग्स नहीं है. थोड़ा सा और इधर लो तो इधर कहीं सफेद दिखेगा। थूक गाड़ो तो भाई
नहीं आएगा। तो you rely on the machines or you rely on patients' findings? Patient is first. Machines are there to help us. पहला SPO2 कभी मत बोलना। पहला क्या बोलना? Patient's condition. कौन सी पेशेंट में क्या देख के ऑक्सीजन चालू करना है? एक एक बोलो। क्या होगा वो पेशेंट में? किसको ऑक्सीजन की जरूरत है? देख के मुझे पता चलता है कि हाँ ही नीड्स ऑक्सीजन। ब्रीदिंग डिफिकल्ट, फास्ट ब्रीदिंग क्या? अच्छा, फास्ट ब्रीदिंग मीन्स इजी ब्रेथलेस, इजी हाइपर वेंटिलेटिंग और इजी डिस्लीप। ये तीन चीज़ों का फर्क पता है? सब में ब्रीदिंग फास्ट होगी, पेशेंट ब्रेथलेस है, पेशेंट हाइपर वेंटिलेट कर रहे हैं, करके आते हैं ना एंग्जाइटी लेके, ट्रॉमा में नाटक करते हैं, एग्जाम पेपर है हाइपर वेंटिलेट। और डिस्नीक, डिस्नीक किसको बोलेंगे? अभी मैं यहाँ 2 माला चढ़ के आई, मेरा श्वास तो चढ़ेगा ना, तो व्हाट एम आई ब्रेथलेस, एम आई हाइपर वेंटिलेटिंग और एम आई डिस्नीक? डिस्नीक मैं ब्रेथलेस, आई एम ब्रेथलेस या आई एम हाइपर वेंटिलेटिंग? एक बोलो। ये तो फर्क क्या है तीन चीज़ों का अलग अलग? ब्रेथलेसनेस किसको बोलते हैं? श्वास चढ़ रहा है, मैं बोलूँगी मैम ब्रेथलेस होगी, चढ़ के आ रही है, ब्रेथलेस, वो मैं बोल रही हूँ, या तुम भी देख रहे हो मेरी श्वास चढ़ रही है, ब्रेथलेस। हाइपर वेंटिलेटिंग, मैं चढ़ के आई ना तो मेरा मेटाबॉलिज्म बढ़ गया, मेरा कार्बन डाइऑक्साइड बढ़ गया, उसको निकालने के लिए मेरे लंग्स क्या कर रहे हैं? कॉम्पेंसेट कर रहे हैं, श्वास ज़्यादा चल रही है ताकि मैं कार्बन डाइऑक्साइड थ्रो करूँ और फिर मेरा रेस्पिरेटरी रेट सेटल हो जाए थोड़ा टाइम। दैट इज कॉल्ड हाइपर वेंटिलेटिंग, विच इज नॉर्मल फिजियोलॉजिकल रिस्पॉन्स। तुम दौड़ के आओगे तो नेचुरली श्वास चढ़ेगी ना, बिकॉज इतना कार्बन डाइऑक्साइड बना है बॉडी में ग्लूकोज जला के एनर्जी देने के लिए कि अभी वो कार्बन डाइऑक्साइड को थ्रो भी करना है मुझे, तो इसके लिए बॉडी विल नॉर्मली ट्राई टू कॉम्पेंसेट बाय हाइपर वेंटिलेटिंग। वो फिजियोलॉजिकल रिस्पॉन्स है बॉडी का। डिस्निया क्या है? पैथोलॉजिकल, always pathological. That means there's some pathology in the lungs somewhere which is causing the patient to become tachypneic. Tachypnea पता है? Tachypnea is also fast rate. Breathlessness is also fast. Hyperventilating is also fast. And dyspnea is also fast breathing. ये फर्क आपको नहीं पता चलेगा तो पल्स ऑक्स देख के क्या होने वाला? Hyperventilating is physiological, normal. Okay? Dyspnea is always pathological. Breathlessness is an experience patient को जो लगता है वो बोलता है, श्वास चढ़ी जाए छे, श्वास फूले छे, रेवातु नहीं, whatever they tell is some discomfort which is causing breathlessness, उसको सांस लेने की तकलीफ है, ऐसा वो बोल रहा है, right? वो सिम्टम है। साइन क्या है? टैकिपनिया, जो हमको दिखता है, टैकिपनिया, हाइपरवेंटिलेशन। डिस्निया किसको बोलते हैं? वो COPD का पेशेंट है एंड इज कम विद एक्यूट एक्सार्बेशन, तो उसका रेट ज़्यादा है बट उसका लंग्स आर ऑलरेडी अ प्रॉब्लम जिसकी वजह से उसको सांस फूलती है। सो डिस्निया इज ऑलवेज पैथोलॉजिकल। कुछ डिजीज है, हाइपरवेंटिलेशन, ब्रेथलेसनेस, टैकिपनिया आर जस्ट सिम्टम्स, समझा? सो मैं डिस्टिंग नहीं हूँ, मैं क्या हूँ? मैं ब्रेथलेस हो गई, मैं हाइपरवेंटिलेट कर रही हूँ ताकि आई वॉश आउट में कार्बन डाइऑक्साइड एंड आई एम टैकिपनिक बिकॉज नेचुरली इट्स अ फिजियोलॉजिकल बॉडीज रिस्पॉन्स, समझा? तो कुछ भी डिस्निया सबको मत बोलना, COPD पेशेंट को बोलोगे तो ठीक है बिकॉज इसके लंग्स ऑलरेडी पैथोलॉजिकल है। ओके, सो दिस इज ओनली डायरेक्ट वे टू डिटरमाइन हाउ वेल द लंग्स आर परफॉर्मिंग द जॉब ऑक्सीजनेटिंग द ब्लड। ओके, सो असेसमेंट ऑफ ऑक्सीजनेशन इज वेरी इंपॉर्टेंट, राइट? समझा? उसको किसको ऑक्सीजन देना है, हाँ वो बात कर रहे थे ना अपन, उससे ये बात आ गई। तो मैं अभी जीना चढ़ के आऊँगी, यात्रा चढ़ के आऊँगी और टैकिपनिक होगी तो मुझे ऑक्सीजन लगाओगे? क्यों नहीं लगाओगे? मैं टैकिपनिक हूँ, डिस्निक हूँ, डिस्निक हूँ, मुझे COPD है, वो आपको पता नहीं है बट हिस्ट्री पूछ के मुझे पूछ सकते हो, राइट? बट अगर मुझे COPD है तो मे बी आई एम डिस्निक, राइट? वो हिस्ट्री पे से पता चलेगा। सी नोन पेशेंट हो, पैथोलॉजी हो तो डिस्निया। आई एम हाइपरवेंटिलेटिंग, यस, बिकॉज आई एक्सर्टेड ना, सो आई एम बॉडी इज रिस्पॉन्डिंग बाय हाइपरवेंटिलेटिंग, वॉशिंग आउट, राइट? सो आपको ऑक्सीजन किस में चालू करना है?
બધા અલર્ટ થઈ જઈએ એમ. તો આ બાજુ જે પેરામીટર બતાવે છે એ પેશન્ટના પેરામીટર બતાવે છે અને આ બાજુ મેન્યુઅર્સ બતાવે છે, જે હું તમને 1 by 1 બતાવીશ. ઓકે, તો હવે જ્યારે હું ટાઇડલ વોલ્યુમ ચેન્જ કરું છું તો હું આને ટચ કરું છું. ઓકે, અને મારે કરવું છે 400, તો એક હું અહીંયાથી બી કરી શકું. બરાબર, આ 400 કરીને ટચ, ટર્ન એન્ડ સિલેક્ટ થયું 400. ઓકે, બીજી રીતે હું અહીંયા આ રેસ્પિરેટરી રેટ મારે 15 કરવો છે તો અહીંયાથી બી પ્લસ માઇનસ થઈ શકે. ઓકે, આ 15 અને સિલેક્ટ ગ્રીન અને 15 થશે. આઈ રેશિયો પેશન્ટનો ઓટોમેટિક સેટ થશે, જે આપણે ફ્લો રાખ્યો હોય એ પ્રમાણે. પીપ ઇઝ 5, નોર્મલ ફિઝિયોલોજિકલ પીપ. પીપનો મતલબ છે પોઝિટિવ એન્ડ એક્સપિરેટરી પ્રેશર. હવે નેગેટિવ પ્રેશર અને પોઝિટિવ પ્રેશરમાં ડિફરન્સ શું છે? આપણે નોર્મલી શ્વાસ લેતા હોઈએ તો જે બેઝલ અલ્વેઓલાઈ, લંગના જે લોઅર મોસ્ટ એલ્વેઓલાઈ છે એ કોલેપ્સ નથી થતા, પણ જ્યારે વેન્ટિલેટર મૂકીએ ને તો એ પીપ 0 થઈ જાય છે, એટલે આપણે 12 થી 5 પીપ આપવી પડે. પણ પીપ વધારે, જેટલી વધારીએ એટલું ઓક્સિજનનું પ્રમાણ વધે, પણ એટલું પ્રેશર પણ વધે. એટલે પીપ હંમેશા પેશન્ટના પેરામીટર જોઈને નક્કી થાય કે કેટલી, પણ 5 જે છે એ ફિઝિયોલોજિકલ પીપ છે. ઓકે, એટલે અને FiO2
time of travel. You can see. Identify the structures which are possible.
Which is cornea, jumbo,
Yes.
iris, lens,
Correct.
pictures.
Yes.
Retina.
Retina.
Very
Yeah.
good.
Nice.
So now we can again put the code to check optic.
Yeah. Try to look for optic now. Yes. You see, it's coming right.
Now one thing we will learn how is to measure optic notion diameter. How do we do that? So this point where the optic is measure this. So we check the all the way. Then we draw a line horizontal. So point 4. What is the normal measurement? So it should be less than.
यहाँ पे ऐसा हॉरिजॉन्टल रख के इसको कंफर्म करने के लिए क्या करते हैं कि इसको ऐसा वर्टिकल रखोगे ना तो ट्यूब लाइक स्ट्रक्चर दिखेगा आयोटा, सो दैट यू कैन कंफर्म द आयोटा इन द वर्टिकल. हाँ, यस, सीधा सीधा आयोटा. इसमें पल्स वेव डॉपलर रख के कंफर्म कर. दो बार प्रेस. हाँ, ये रहा. चलो उसको प्रेस कीजिए. नाउ यू मेजर दोनों साइड, बाहर से बाहर तक करना.
ना पूछी कर. So हाँ 4 तो हो जाएगी.
सेम लेवल पे एंगल जहाँ पे बढ़ जाएगा.
Yes.
पल्सेटिव एंगल.
Yes.
सो ये mm है.
Yes. We are going down. See,
कंप्रेसिबल कौन सा
medial.
है बताओ.
See, compressible.
Yes, ठीक है ना. Always the more rough.
Sometimes patient is hypovolemic. Oh yes. With your pressure get compressed, you cannot identify vein also. Just for screening also, you can do this. हाँ वही हाँ.
Sir, known as Mickey Mouse sign. You can see the difference between the vein and artery. So medially क्या होगा?
Vein
होगा. What is the formula? VAN. So VAN. Vein, artery and nerve. Yes.
Down is not possible.
कंफर्म करने का बेस पे पल्स पर डॉक्टर रखो.
One AVL ખાલી આ એઓર્ટિક વાલ્વ વાળો વ્યૂ છે એ જોઈ લો કારણ કે ઇટ ઇઝ અધરવાઇઝ ડિફિકલ્ટ ટુ ઓબ્ઝર્વ. અહીંયા આગળ આ જે આપણને જોવા મળી રહ્યું છે અહીંયા આગળ આ એઓર્ટિક વાલ્વ છે, ધેટ ઇઝ મર્સિડીઝ બેન્ઝ સાઇન.
at times so yes, one thing more, when the first thing આપણે જ્યારે blacks view જોતા હતા,
right, see a movement દેખાય, so that is long sliding sign. So long sliding sign normally કેવી હોય, absent કે present? Present. So આપનામાં છે, so it is normal, abnormal? Normal. હવે આપણે મૂકીએ M mode. M mode ક્યાં મૂકવાનો? રિબ્સ પર ના, બે રિબની વચ્ચે, રાઈટ, બે રિબની વચ્ચે મૂકીને M mode પ્રેસ કરીએ તો આપણને શું દેખાય છે? સી શોર સાઇન, રાઈટ. સી શોર સાઇન નોર્મલ કે નોર્મલ? નોર્મલ. આનામાં દેખાય છે, નથી દેખાતું? તો પેશન્ટને ન્યુમોથોરેક્સ છે, નથી? નથી. જો ના હોય, સી અપર, રાઈટ લોઅર, લેફ્ટ અપર, લેફ્ટ લોઅર, એવું નહીં કે ખાલી અહીંયા જો લીધું એટલે ઓલ લંગ્સ આર નોર્મલ. બની શકે કે ફોકલ ન્યુમોથોરેક્સ અહીંયા હોય, તમે અહીંયા 3 જગ્યાએ જોયું, પછી થાકી ગયા, નથી જોયું, એવું ના છે, રાઈટ. સો one by one we'll practice, starting with right upper quadrant, left upper quadrant, barrier cycle, sub-zipper એ નથી દેખાતું, then lumps. Lumps તમારા સેકન્ડ હાફમાં છે જ, only lumps. So
string of pulse છે, એના માટે અલગ સેક્શન છે.
આ સ્ટ્રિંગ ઓફ પલ્સ છે અને આ કાર્ટિલેજ છે. તમે
આ ક્રિકોઇડ કાર્ટિલેજ એકદમ ગોળ છે, બરાબર. એટલે આને થોડુંક વચ્ચે રાખવાનું તો તારે મેમ્બ્રેન ખબર પડે.
એની માટે તારે આને ઉપર લઈ જવું પડે. એટલે એવો વ્યૂ રાખવાનો. ઉપર જઈશ તો આમ આવશે, નીચે જઈશ ને તો વધારે સ્ટ્રિંગ ઓફ પલ્સ આવશે, કારણ કે નીચે તો બધી ટ્રેક્યુલ રિંગ જ છે. એવી રીતે સો યુ હેવ ટુ ફોકસ વેલ, તો જ આપણને ખ્યાલ આવશે. જો એવો વ્યૂ લાવવાનો કે જેનાથી ટ્રેક્યુલ રિંગે દેખાય ને બે કાર્ટિલેજે દેખાય, જે સેન્ટરમાં.
લઈ લે ભાઈ.
નહીં તો એટલું બધા
પછી અમને આપી દેજો, બીજું આવે ને એના પછી પૂછી કાઢે. એપિગ્લોટિસ એકચ્યુઅલી અમારા માટે વધારે ઇમ્પોર્ટન્ટ છે. જે ઇન્ટ્યુબેશન કરવાનું હોય ને એ ડિસ્ટન્સ જોવાની, સ્કિન ટુ એપિગ્લોટિસ. વધારે હતું ડિફિકલ્ટ લેરિંગોસ્કોપી,
ऐसे ही नहीं दिखेंगे मैम, किसी को आगे ही नहीं आना, क्या करेंगे? यहाँ पे कितनी सारी जगह है, देखो भाई आ ग्रुप ओछું પડે તો પાછું એ એડ કરો, એ નહીં આવે એમને નહીં. અલે એકે સાઈડ નહીં આવે, કટ ટુ કટ થઈ ગયું. હવે મારે આ બારીન બહાર જવું પડે પાડવું હોય. હા ભાઈ માની જવું, પછી અત્યારે લાઈવ વર્કશોપ થઈ જાય મારે.
Has anyone seen this procedure being done? So it is very rarely conducted. So in today's activity, after the activity is over, what we will all gain? So at the end of this session, we will be able to identify the situation in which this critical procedure is performed. So we have to first identify where we should do this procedure. We should be aware of any consent that is needed to be taken or not to be taken. Okay? Then organize team, instrumentation and whatever equipments we need to conduct this procedure, and grasp the very basic skills of this procedure. Okay, next slide please. Okay. So first of all, what is it? What is this procedure known as? Perimortem. The word perimortem means a person is almost about to die. In that situation, we are conducting this procedure. So there is some aim, isn't it? Why should we do such a procedure in a person who is dying? So what is our aim? So it is essentially done done in situations for pregnant women who have suffered a massive cardiac arrest during resuscitative efforts, in order to relieve the maternal aortocaval compression. So because of the enlarged uterus, it is compressing the aorta and the venous system, isn't it? So in order to relieve that, so that the other emergency team can take over the resuscitative procedures. Okay. So it is aimed at facilitating both maternal and fetal survival. Okay. Not just the fetal survival, also maternal survival. It is also known as resuscitative hysterectomy, as the procedure is primarily used to assist maternal resuscitation. So the primary aim is to save the life of the mother, to facilitate the resuscitation of the mother, so that load is taken off. Okay, next slide please. So why it is done, as I have already told you, to relieve the preload, improve the pulmonary mechanics through improved diaphragm exertion, to reduce the maternal oxygen demand. Why? Because a large part of the oxygen demand of the blood circulation is shifted to the fetus. So as the fetus is taken out, now all the blood and oxygen can be directed to the mother itself. Okay, and also if possible to save the life of the fetus, because as fast as we can deliver the fetus, the chance of survival of the fetus is also better. Okay, so there is no timeline like when we should do it, but till how much time we will be able to save the baby. However, it has been seen that after 15 minutes of post-arrest, maternal survival and fetal survival after 30 minutes have also been documented. So when should this procedure not be done? Okay, so first of all, if the age is less than, gestational age is less than 20 weeks, why? Because below 20 weeks, the uterus will not be putting a lot of compression, isn't it? So the preload will not be affected much by the fetus. Then if a physician who is not trained to do the procedure is not available, and mostly if the patient is already resuscitated with advanced life, suppose within 5 minutes, okay, then the patient can be taken to the OT and a proper procedure can be done afterwards. Okay, so what should we have with us? So the availability of certain equipments to perform the procedure, okay, surgical equipments, and to resuscitate the neonate. Okay, if possible, if feasible, a consent should be obtained. Okay, it is recommended that we should start the procedure within 5 minutes of failed resuscitative procedures, and to deliver the baby within 4 minutes. Why? Because after 4 to 6 minutes, the oxygen deprivation to the fetus starts, and it can have hypoxic insult. Okay, alright. Okay, so while doing this procedure, first we will encounter the abdominal wall. So we have to cut through the layers of the abdominal wall. First we will have the skin, then the subcutaneous layer. After that the fascia, which is the rectus sheet. Okay. After that the rectus muscle. So we will not be cutting very slowly like we do in a normal surgery. We will just go in one go. Okay, through the abdominal wall. Okay. And then after the peritoneum, we will have the organ, that is the uterus. There also we will do a vertical incision, that is easier and faster. And then we will deliver the baby. Okay, you will see that in the activity which we will be doing now. After delivering the baby, basic hemostasis we will have to achieve, and then the resuscitative team will take over. Okay, if the patient survives, suturing and all can be done later on. So this is the classical approach which we will be going from the xiphisternum to the pubic symphysis. We can give a big long cut, okay, to open up the abdominal layers so that we can reach the uterus. Okay. So anybody has anything to ask?
As per so there rules in MTP Act that only such and so trained obstetrician can perform MTP certain criteria. Is there a criteria for PMCD?
As far as I know, there is no such criteria. This is an emergency procedure, and actually anybody should be able to do it. Okay. In fact, not doing the procedure in a proper scenario could cause us problem. Like if there is a potential candidate who might survive because of this procedure, and we have not done it for some reason, then we may be in a suit. Yes.
So ma'am, consent is not needed.
Consent is not needed because we are doing in the goodwill of the patient. But if the relatives refuse, like the DNR consent they are giving, do not resuscitate, then we might not be able to do it. But samne se they tell that we do not want. Otherwise, if they are not saying anything, then we can go ahead.
And is the consent like legally valid?
That is what I am telling you.
Okay.
So till now, no lawsuits have been filed for performing this procedure. But see, I have already put it here. 2 lawsuits have been levied against doctors who have not done the procedure, which could have probably saved the life of the patient. So we can always retrospectively tell that we did it in the best of the interest of the patient. Okay, that much leverage we have as doctors.
Okay. Thank you.
Thank you. Okay. Thank you.
Try to show you. With the TDI on, what you get similar one, but a mirror image. Upside down image. E dash, E prime, what is called an A prime. First one is E prime, next one is A prime. You look at velocity, पहले बड़ी होती है फिर धीरे धीरे कम होते जाती है. Correct? So as you go on higher dysfunction, the E prime velocity reduces and A prime velocity goes on increasing. So now diastolic dysfunction grade 2 from normal. Next is the valvular emergencies. Correct? Valvular emergencies. We get patient with a chest pain. Chest pain could be because of the aortic stenosis, correct? So in such a case, what do? We look at the aortic right hand side or longitudinal flap in the ascending aorta. Okay, with the AR presence of aorta, that may be suggestive of aortic dissection. Cardiac and trauma, basically we try to look at the tamponade. There could be sometime RWMA because of coronary artery, injury there, but most of the time we look at tamponade. Dyspnea, you have to follow the protocol. Okay. So what you look at, a blue protocol you have to follow. You have to look at A lines, B lines. There's another algorithm, very difficult to cover up this thing. But if you find like a heart LVEF is low, and if you find multiple B lines, you know this patient is having tachypnea because of cardiac origin, cardiogenic. And if he has a B lines and without contracted is okay, so most likely it's a lung pathology. Could be ARDS, could be something localized consolidation with localized B lines. So this is how dyspnea evaluation helps, echocardiogram helps between the cardiac and the COPD. It can be helpful in procedural guidance also. Suppose I want to do a tapping of the pleural effusion, pericardial centesis, then also echocardiography could be useful. Field protocol already we have seen. Okay, these are protocols I have written. The false protocol is basically when you try to give fluids by ultrasound guidance. So you give fluids, you watch the lungs. The A lines are there, you go on giving fluids. When the A lines turn to the B lines, A line turn to the B line, that is the time where the lungs are getting congested, you have to stop. So fluid assessment limited by lung ultrasound. Okay. So false protocol basically to assess the fluid based on the lung and echocardiography. Rush protocol already I told you, initially in hypotension with the cardiogenic shock and hypovolemia. Rapid. Then the E-fast protocol we do in the trauma, where you try to look at the different quadrants, right upper quadrant, left upper quadrant, pelvis. We look at the Ziffy sternum and the simultaneously pleural cavity also. That is the E-fast protocol. So this was all about the echocardiography. Because of lack of time, I am not going to details of that. But you can basically evaluate for the systolic, evaluate for the diastolic, evaluate for the valvular abnormalities, evaluate for the fluid status, the contractility, aortic cases, dissection, chest pain, dyspnea, and this I don't know how much time we'll get hands-on to show you. If we have a pathological case, definitely I can assist you. We'll be having a normal cases bedside. So normal cases, whatever best possible, we'll try to show you. Any questions?
Thank you very much, sir, for the next session will be a regional block by Dr. Jismi.
So good afternoon, everyone. Sorry to wake you all up. Post-lunch syndrome से बाहर आए. Sir gave an enormous and very beautiful talk on echo. I hope you all could get the best out of it. सुनाई दे रहा है? नहीं मैं फिर भी सो रहे हैं. Okay, so my topic for today is regional in trauma basically. But how many of you have given regional anesthesia or blocks in trauma? Okay. How many of you have seen regional blocks? Pura haath ऊपर कीजिए. Seen and heard of it. And how many of you are wondering what this topic is doing here? Yeah? Okay. So, regional plays a very important role in trauma, in pain management, in anesthesia. So, it is a conception कि ये तो anesthesia का topic है यहाँ क्या करना है. But, mind me, when your patient comes to you, his main complaint would be pain. And when you relieve that on the spot, you win the confidence there. Okay. So these are the various situations which you can come around in trauma, and blocks will be helpful in most of them. So as we discussed here, why regional? Because it gives rapid analgesia, the most common indication. Second, it is safer. We require less sedatives, less opioids. So the patient who is coming to you can be any patient, an OSA patient, obese patient, polytrauma patient. So in those patients you want to avoid opioids. 2, avoid their breathing to be affected. So best in rib fractures, in femur fractures, wherever, you name it and you can give. Okay. Shorter stays in ED, most important, higher patient satisfaction. And even more important is, it is trending in ER trauma. So whatever is trending we do, right? Next, the question is, who can give these blocks? Who can give? Any idea? Anesthesiologist. I will say any trained person. So even an emergency physician who is trained for giving these blocks can use for pain relief. Okay. Where to give? You can give at the bedside. So you did not shift the patient to any procedure room for doing this. This can be done even at bedside. You just need adequate monitoring your USG machine. Okay. Now, when to give and what? So when to give would be after you have done your initial resuscitation, your secondary survey, you have assessed pain. You can use any pain score whichever is being used in your institution. Okay. After that, we will determine the location of injury, and based on that, we will decide which block we want to give. For example, for upper limb, you can use brachial plexus blocks. For truncal, you can use spatial plane blocks like serratus anterior, erectus spinae, and for lower limb like femur fracture, tibial fracture, you can use lower limb blocks like fascia, iliaca nerve blocks, femoral nerve blocks, sciatic nerve blocks, popliteal sciatic, individual nerve blocks can also be given. Okay. Now, how to give? How to give is very simple. We have three techniques. One is landmark guided, one is peripheral nerve stimulator, and one is USG. Landmark means we used to do it. You actually draw all the landmarks on the patient, and you just insert a needle at the location of the nerve. The patient will say that some sensation is felt. Okay, and there we give the drug blindly. We are giving the drug blindly, so it has its own adverse effects. We don't know what structure we are piercing, what injury we are causing. Okay. Next is peripheral nerve stimulator. So this is a machine called peripheral nerve stimulator. We commonly use in anesthesia. We require a needle for this. This is called stimuplex. So how it works is, we connect this needle to the machine. We set some current. We insert the needle at the nerve location, and we give current to that patient. And with the reflexes generated, we come to know that okay, this is the nerve and we have to do it. Little bit complicated. Okay. So that is why the next one is USG guided, which we will be learning. Now, what drugs can be used? So there are multiple drugs, mainly local anesthetic agents like bupivacaine, bupivacaine, ropivacaine, lignocaine plain, and with adrenaline. Concentrations, they can be available in different concentrations, and the dose has to be calculated according to the patient's lean body. Okay. What if you exceed the dose? Why this dose is important? Yes, so it can cause local anesthetic system toxicity. So these have to be injected perinurally only. If you inject it IV, it can lead to last, or if you exceed the dose, it can lead to last. Last is, as you all said. Now for today, we will limit ourselves to only these blocks for upper limb, supraclavicular and interscalene, and for lower limb, femoral and popliteal sciatic. Because it is a very vast topic and we cannot finish everything in 30 minutes. Prerequisites, of course, you need a trained performer, consent from the patient, you require a USG machine with a linear probe, drugs, needles, syringes, extension tubing, and whatever you require to prepare the patient. Okay?
I'll just brief about the upper limb block. Lower limb we will directly discuss on the station. So this is brachial plexus and this is the anatomy wherever it supplies the upper limb. Simple or complex? Simple or complex? Difficult to understand? It's simplified. So this is your brachial plexus. So it is supplying your entire limb. Okay? Where we will be blocking it? So the different approaches are nothing but blocking the same plexus at different locations. Okay? So this is the clavicle. If you block above it, it becomes supraclavicular. If you block below it, it becomes infraclavicular. And if you block at the region of neck, it becomes interscalene. Simple? Okay, so I have shown the probes here. When you put it on the neck, it becomes interscalene, supra, infra and axillary when you give it axillary. These are the various injection points. Supraclavicular, we will demonstrate at the station how the probe is kept, how do we scan. I'll just brief you the indications you can use for your entire upper limb, forearm fractures, wrist injuries, hand injuries. Okay, benefit is entire limb can be blocked. This is the area covered by your supraclavicular nerve. Okay, almost the entire head. Next is interscalene. It is used for shoulder dislocation reductions in trauma, especially when there are anterior shoulder dislocations, clavicle injuries. Only thing is you have to avoid it, severe respiratory compromise. This is the area supplied by interscalene block. Next we will take directly on this. Are we good? Thank you.
Thank you very much, madam. So the next discussion will be on the PSC guided central line by Dr.
Good afternoon, everyone. Feel sleepy? My topic is central USC guided central line insertion. So, normally we are practicing landmark guided, but today my topic is USC guided central line insertion. So, it reduces 71% failure rate. It reduces 75% arterial puncture, and USG guided central line reduces 80% of pneumothorax. That's why in newer generation we are preferring USG guided central line. So there are some trial and guideline. NICE 2002 guideline says that USG is real time mandatory for the central line insertion. There are many trials. Also suggested data that it has a less complication. So we are now preferring USG guided central line. So which side is to select for the vascular access? There is a three side: internal jugular vein, subclavian and femoral. Femoral has a high infection rate and DVT, so we are least preferred. But when there is a cardiac complication, patient is having arrhythmia, at that time we are preferring femoral vein insertion. Subclavian is most comfortable for patient because the neck movement and leg movement doesn't interfere with the vascular access. But subclavian has a high pneumothorax risk and it is difficult to compress. When the subclavian artery is pierced, you cannot compress. So there is a bleeding inside the chest cavity. So it is hard for a performer. And the internal jugular vein is a first choice because it is lower infection rate. It is best USG visible and it is compatible, and when there is arterial puncture you can compress and stop the bleeding. So step by step there is a 6-step approach. First is preparation, then identification, then positioning. All steps we can perform in the demonstration. The fourth one is needle entry, fifth one is wire insertion, sixth one is a confirmation. So preparation is a key. Because preparation is more important than procedure. काफी बार हम लोग ऐसे जल्दी में आके चलो सेंट्रल लाइन करते हैं, ये नहीं है, वो खुला नहीं है, ढक्कन खुला हुआ है, bleeding gauze piece ready नहीं है. So you should prepare well. If you do prepare well, it is easy for the procedures. So for the preparation, informed consent must be taken. You have to check the coagulation profile and PT-INR. You have to site selection and it should be marked. You have to time out the perform. Sterile field should be prepared. USG probe should be sterile. Flush all the lumen. emergency equipment are ready. Here patient is attached to the monitor. The positioning of patient should be confirmed. So all preparation you have to check मतलब पहले से ही ये सब check करके रखना. There is equipment needed. There is a list of equipment. This is central line kit. We can see that the lignocane, the guide wire, the scalpel, needle driver, sterile dressing, all should be in front of you while you do a procedure. So I will start with the sonographic anatomy. So all three vascular access, whenever you put, you have to use a linear probe for this. So in the morning session, vascular focus, ma'am has covered all the things. How to confirm whether it is artery and vein. There is a three main difference. Artery is compressible or not? It is pulsatile. Okay. And vein is a thin wall and compressible, and it is oval in shape, and it is more in size than the artery. So in the all three axes, we have to put the probe, linear probe over the area. We have to confirm which is the artery and vein, and then I will see you how to do the procedure. After you confirm there is a vein, you can insert USG guided. So there is a two approach: in plane long axis or out of the plane short axis. So what is the difference between these two? Out of plane short axis, in which your vascular structure वो round shape में दिखेगा, okay? And in plane long axis, in which your vascular is a longitudinal ऐसे दिखेगा. जैसे हमने airway में देखा था, तो trachea circular ring देखेगी. जैसे ही हम plane we will change, it will be longitudinal. The same way in the vascular axis. So this is in plane long axis view, and that is out of plane short axis view. Okay. The another way is to confirm artery and vein. It is to be color mode. When you apply color mode on the USG, you can easily differentiate whether it is artery or vein. One more thing, I told you that subclavian, the more chances of pneumothorax, and if subclavian artery will bleed, we don't have option to compress it. But if you do subclavian, which is more comfortable to the patient, USG guided, then the complication is less. So in a subclavian also, you have to put a probe, you have to identify with the color Doppler, then identify the vein, and then you can insert USG guided subclavian central line. The cannulation of internal jugular vein, there is a long axis approach. I am showing you image. In a demonstration, we will show you on the mannequin. This is the vein which is compressible. This is a Schrödinger technique step-by-step detail. You all resident know what is the steps of the central line. It is after all preparation we have to puncture with the needle. When vein is confirmed, you have to introduce the guide wire. After guide wire introduction, you have to remove the needle, and then we have to do a track dilator, two dilator at red and white. We have to dilate with this two dilator, and then we have to place the catheter, remove the dilator, and we have to confirm the flow. This is the vascular access procedure. Landmark guided and USG guided procedure remains same, but in the USG guided you have to identify vein with the USG view, and in landmark you have to do a blind procedure. Both the procedure remain same. So post procedure complication are there, but USG guided there are less complication. There may be arterial puncture, there may be pneumothorax, there might chances of infection, so you have to maintain a aseptic precaution, and there are wire and tip malposition. So USG will reduce most of the complication. So if you do USG guided procedure along with asepsis, you will be good to go. There are special situation and contraindication, like if your coagulopathy and thrombocytopenia are there, if your INR is more than 1.5 or platelet less than 50K before the procedure, that is a contraindication. You have to correct first and then you should do the procedure. Also USG reduces hematoma risk at the puncture. Obesity and difficult anatomy, that is also a special situation where USG is a mandatory. In normal thin and lean, you can do a blind procedure. In the obesity, that is much difficult, so you can go for the USG. pediatric patient. In pediatric, this USC guided central line is more important because neck is short, the structure is very small, and if you do blind, you are going of distance, the structure been distorted while you do a blind 2 to 3 attempts. At the previous fail attempt, when you have 1 to 2 fail attempt, go directly with the USC because it will more benefit to the patient. It reduces attempt and reduces the complication. So the key takeaway, real-time USC guided central line is more superior than landmark guided, but both the way we can do the procedure because in a limited resource setting when we don't have the USC, we can go for the landmark guided. Any question in that? This is more practical thing, so we will do on the workstation. Thank you.
Thank you very much. So the next session will be the landmark guided central line by Dr. Kemkon.
Good afternoon, everybody. Why is this needed, this lecture, this 15 minutes interval? I have already covered everything, I think. But why first you know the landmarks of inserting a central line, or why should you know this technology? There is already a workstation system here. So the entire procedure of ultrasound, landmark kahan se aayega? Why is it necessary? According to you, I want 1 or 2 answers so that we can move fast to the workstation. Please, anybody. That is fine. What else? Anything else? How many have USG available with them wherever they work? All the time. 1, 2. Bas? So, isn't this more important if you don't have? So, whenever as Madam said, whenever the resources are less, you must know what is the basic foundation on which this entire thing was built. That is why we are going to discuss this. Why I am sharing one of my experiences. There was a patient of oral cancer operated with a PMMC flat, the pectoralis major flat. So, subclavian पण गई, IJV पण गई. But patient went into arrest in the ICU. IV line out થઈ ગઈ, CPR આપતા. જે માણસ ચડીને CPR આપતો તો એને IV line out કરી. હવે next thing that I could do was insert a line or 18 gauge needle directly into the femoral vein just because of landmark, because I did not have the time to bring the USG which was on the other floor of the hospital. Okay, this is a real case scenario. That's where this helps, this knowledge. Okay, so what are the different scenarios where you need the equipment? Emergency situations when ultrasound is getting used by somebody else, there might be only one ultrasound available throughout the floor, and resource limited settings. So internal jugular vein landmarks, the triangle between the cervical mastoid heads, apex and the clavicle, and carotid artery, which is on the medial side. You have to compress the common carotid artery with your left hand or your non-dominant hand and insert the needle just lateral to it. Subclavian landmarks are 1 to 2 centimeter below the clavicle. We'll show you on the workstation. You have to your hand like this, and the needle direction should be towards your index finger, which is kept at the clavicular head of the sternal head of the sternal mastoid. Patient position should always be in the Trendelenburg position. Why is this? Anybody from anesthesia might be able to help. Yes, one of you, please. Why is Trendelenburg position important in this way? Head low के बराबर पड़ता है. More prominent. To make the vessel prominent. Second, to avoid air. Very good. Femoral vein landmarks are patient. Please remember navel. Keep the femoral artery compressed with your hand. Towards the side. Always remember this is lateral to medial. Navel is lateral to medial. So, artery, vein. Which one is lateral? Artery is lateral. Okay? Here, for Internal jugular artery is medial. Oh, oh. ठीक है, okay, 30 to 45 degree angle, aspirate continuously, that non-pulsatile blood. This is very important. Whenever you aspirate, the blood should be dark and it should be non-pulsatile while inserting your guide wire. Skin to vein depth is usually 1.5 to 3 centimeter. We can show you on the, if you have USG available, you can always assume the depth, or there is another formula available on your sites where you can calculate and everything, and you can get exact decimal point, which will not be helpful to you. You will be wasting time. That is why I have not kept it. It always depends on BMI. More the weight, larger skin to vein depth, and advanced cautious. Shanti dhime dhime karo. So artery versus vein. So artery is pulsatile and bright red. Vein is non-pulsatile. Confirm before dilation. Always remember, if you are a novice in this, please call for help before inserting your needle. Yes sir, I do not have USG available, or madam, I do not have USG available. Please kindly stay while I insert through length. Barabar? So please confirm. Confirmation is two individuals going to the same path. It is confirmation. Barabar? You may joke. How blood I nakhi do. Guide wire, smooth passage, no resistance. Smooth passage, no resistance means that you just have to insert the needle. You should not have to give more pressure. ECG changes may or may not be seen. If the height is more than 170, 180 centimeter, your guide wire will not reach up to the right atrium to give ECG changes. If you are inserting subclavian or internal jugular. In femoral, so obviously it would not reach. So ECG changes may or may not appear. Dilator and catheter placement. You have to keep the small incision, dilate the tract, remove dilator, railroad the catheter. Never let guide wire out of sight and out of hand. Guide wire हाथ में रहવો જોઈએ. બરાબર? Guide wire અંદર ના જતો રહેવો જોઈએ, guide wire બહાર ના જતો રહેવો. Guide wire જ્યાં છે ત્યાં જ રહેવું જોઈએ. Simple? Everybody with me? Oh. So, deep position confirmation. Always with fluoroscopy. Fluoroscopy is X-ray. Either continuous IITV in OT, like if you are available bedside, well and good. If not, after insertion, please confirm. This is the subclavian vein. This is the internal jugular vein. I hope you can appreciate it from the backside. Can you? Everybody? This is the left-sided subclavian. This one. I know just. I know I could draw very much. Subclavian it would look like this. Its parents said subclavian vein में कुछ एक समय chances से बहुत देखा है. I'm not just. So complications can be misplacement or coiling. You can see. ऊपर થી આમ આવી છે કે આમ થી આમ જઈ રહી છે આપણને નહીં પણ આવું થવાની શક્યતા ખરી તો શું કરવાનું કાઢ નાખો Anybody managing complications? What do you have to do before getting the chest X-ray? Ask the nursing staff to not discard everything that you had prepared. Once you have confirmed the position, only then you have to discard your entire set. મેં ડિસ્ક્રાઇબ કર્યું ને આખું મોટું આખી ટ્રોલી હતી ને એમાંથી એના પર ગાઈડ વાયર મૂકી રાખવાનો એટલે જવા નહીં દેવાનો બરોબર. Once the chest X-ray confirmation is there with you, only then you discard everything. Once your chest X-ray, if there is any displacement of the tip, you can always reinsert the guide wire under fluoroscopy guidance. You can readjust the tip so that you do not have to open another set. Okay, got it? So, different arterial puncture, pneumothorax, aerobolism and infection. Avoiding complications is using proper landmark. Limit the attempts. एक attempt, 2 attempt बनाए ठीक है. Wait for the USG to come or find another peripheral vein if possible. So, strict asepsis should be maintained and position should always be checked. Position of the central vein. Okay. So, these are the guidelines that are available obviously the guideline says ultrasound has to be used. Barabar? We are not promoting the fact that you should avoid ultrasound. Ultrasound has to be used. This is only for your knowledge that in case of a resource limited setting or in case of an emergency where you cannot wait for the ultrasound to come, you must know this so that you can resuscitate the patient as early as possible. So always ultrasound has to be used either way. So first step. Right? Then confirmation you will follow the entire steps. Right? Position, identify, insert, confirm and secure. This is the stepwise approach. Okay? These are my references. You can get it from them. Thank you. Thank you very much, sir.
Then USC becomes a very piece of cake.
Madam, the first thing that we were taught by madam is to become lifelong learners.
Idea is
We have to learn every day.
to be best at your first attempt.
Yes.
This
that is
all
true.
everything puts together that your first attempt should be the best attempt. So that's why you should know both of the things.
I have taken lecture on USC guidance, but in the residency I did all blind attempts.
I also, yes, exactly, ma'am. Until I came in emergency medicine, I was doing blind identification.
So I'm expert in that one guidance.
Yes.
The last session will be the non-ultrasound by Dr. Abhishek today.
After USG guided or landmark guided, what we start?
What is lung sliding? Everybody has learned it. Those who are sleeping at the back are getting bored. Let me have a quick introduction till Dr. Abhishek says it. What is sliding? You sure? Yes, that gives a sliding movement, a zittery or a shimmering line on the USG, and that says that there is some fluid between visceral and parietal pleura. Of course, he is going to teach him. But about your first lecture, what is McConnell sign? But why we should know that? It diagnoses pulmonary, suppose it diagnoses pulmonary embolism, why we should know that? Why there is so much emphasis on learning this rush protocols, fields protocols?
Early diagnosis.
Of what? Pulmonary embolism. Of a treatable condition. Because treatment is very simple, right? Thrombolysis patient, your patient cannot go for CTPA, but still you can save a life by giving anticoagulant. Then the second thing was, okay, you're ready, you can take over.
So our last is the lung ultrasound, right? It's very important component of the focus. If anyone working in emergency should know, if you are holding the probe, should know the lung ultrasound now, right? Why? So first of all, people starting the lung ultrasound, some physiological facts about the ultrasound waves. So ultrasound waves can traverse fluid, can traverse tissue, can traverse muscle, can traverse bone, can traverse fibrosing, but cannot traverse air. Whenever there will be air in between the pathway of the ultrasound waves, the waves will be reflected back. Right? This is the basic thing we all must understand. So what does that mean? जहाँ पे air आएगी, उसके beyond we cannot see with ultrasound waves, right? So whatever the structures beyond this air, we will not be able to visualize. So ultrasound must जो image बनेगी, वो कैसे बन जाएगी? जहाँ पे हमने probe रखा है, जैसे ये probe रखा है मैंने, यहाँ पे, और यहाँ से लेकर air तक जो structure है, it will be visible as a real structure. Air के beyond जो भी है वो नहीं दिखेगा. तो उसके beyond जो भी है वो क्या आएगा? These all are artifacts. Right? This is the basis of lung ultrasound. Because lungs are filled with the air. यहाँ पे airway में लिखा होगा सुबह वो lecture में, right? Air is also here in the airway. तो similar way जो हमारा probe जहाँ से रखा है skin से लेकर और दूसरा एक जो हमारा क्या बोलते हैं logic. This is one structure on terminology called air tissue interface or air mucosa interface or reverse tissue air interface or mucosa air interface. What is that? जहाँ पे रखा probe तो स्किन, सॉफ्ट टिश्यू, मसल, उसके बाद जहाँ पे एयर है, तो जो एयर और टिश्यू का जो जंक्शन बना, दैट इज कॉल्ड ATI, एयर टिश्यू इंटरफेस. So that air tissue interface will be reflected as a hyperechoic line in ultrasound image, and from that in ATI that waves will be reflected back. बराबर ना? तो हमारा इमेज जो बनेगी अल्ट्रासाउंड की, उसके अंदर सबसे हाइपरइकोइक वाइट लाइन जो होगी, दैट इज एयर टिश्यू इंटरफेस, जहाँ पे एयर और टिश्यू का जंक्शन है. बराबर? तो उसके बियॉन्ड जो दिख रहा है वो ऑल आर आर्टिफैक्ट्स. वी कैन नॉट stamp that this is real image or this is the real structure. Okay, so this is the basis of lung ultrasound. Now remember this. Now for evidence point of view, I have taken this point only. Lung ultrasound is a large topic. Right? Thoracic ultrasound is we can do a 2 days also. But for evidence point of view, these things I have only covered here. So this is very good ISSB manual physical ultrasound. I am also one of the author of these things. And some of the material I have taken from our ultrasound fellowship, which is this is the ultrasound fellowship of 1 year. I am the Catalan examiner of this thing. In your emergency conference, I am promoting my fellowship. Sorry for that.
No, you can.
This is our book, right? But it's okay because this is the only book in the world which covers the whole head to toe and ultrasound pathologist in a step-by-step manner. So if you want to know something more, you can refer this book. So now, some basics, I will not go into deep. For lung ultrasound, we can do with all these 3 probes. This is curvilinear probe, this is linear probe, and this is case data probe. In some institutes or some location, only this probe is there. With this also, we can have some view in lung ultrasound. This is this is also linear means कौन सा high frequency probe. ये 2 है low frequency, right? So this. Now remember this thing of mnemonic in ultrasound, PPDG. Remember everywhere. Whenever you are using focus, first we have to select the probe appropriately. Then appropriate preset we have to set, right? Then appropriate depth, and then appropriate gain. PPDG you remember everywhere. Okay? With all appropriate of these things, we will have an exact, very good view of that structure. Okay? From head to toe, each view has its own quality controls. So कितनी डेप्थ होनी चाहिए, कितना गेन होना चाहिए, यहाँ पे कितना प्रीसेट यूज करना चाहिए. तो बाय डिफॉल्ट लंग में कौन सा प्रीसेट यूज करेंगे? लॉजिक लगा आपने अभी मशीन साइड काफी लोगों ने देखा कि नहीं होगा. तो प्रीसेट क्या होना चाहिए लंग के अंदर? लंग प्रीसेट क्या होता है वो डॉक्टर सिद्धार्थ सुबह दिखाया. तो एक स्मॉल स्ट्रक्चर होते हैं, नर्व्स होती है, वेसल होती है, राइट? लंग होता है, एब्डोमेन होता है. इतना प्रीसेट मोस्टली हर एक मशीन में होता है. ना अभी जो मशीन आ गए जो हाई एंड वाले AI वाले, उसमें तो बहुत सारे हैं प्रीसेट. उसमें वेसल का अलग से प्रीसेट है, फैट का अलग से प्रीसेट होता है, अलग से सीन्स ऑफ टिश्यू का अलग से होता है, बॉन का अलग से होता है, राइट? वी कैन हैव अ वेरी गुड इमेजेस नाउ इन द न्यूअर मशीन्स नाउ. क्लियर? सो PPDG फॉर एप्रोप्रिएट डेप्थ, मतलब आपको वास्कुलर स्ट्रक्चर देखना है तो डेप्थ शुड बी वेरी मिनिमल. अगर आपको एब्डोमेन कैविटी देखनी है तो डेप्थ शुड बी एटलीस्ट 16 सेंटीमीटर. अगर आपको हार्ट देखना है तो एटलीस्ट इट शुड बी अराउंड 10 to 14 सेंटीमीटर. सो PPDG वी शुड रिमेंबर. इकोजेनेसिटी फिर से ये कर लो, इसका ये थोड़ा रिवीजन. हाइपरइकोइक विल बी व्हाइट, हाइपोइकोइक विल बी ग्रेइश, मतलब जो हमारा नॉर्मल स्ट्रक्चर जो दिखते हैं स्किन ऑफ टिश्यू मसल वे ग्रे दिखते हैं हाइपोइकोइक. आइसोइकोइक मतलब थोड़ा लोअर है, ग्रेइश हो. और एनिकोइक इज ब्लैक. तो फ्लूइड जो है वो अल्ट्रासाउंड में ब्लैक दिखेगा, राइट? तो हमारा जो गेन एप्रोप्रिएट है कैसे पता चलेगा? तो जहाँ पे फ्लूइड होता है, जो नॉर्मली जहाँ पे जैसे हार्ट में फ्लूइड होता है, जो ब्लड होता है, दैट फ्लूइड शुड बी विजिबल एज ए ब्लैक, वेरी 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 ब्लैक. Then our gain is appropriate. If this fluid is appearing white, then our gain gives that very high, and that black fluid is appearing very very on the grayer side, right? Then our gain has that low. So in that way we can adjust our gain. Clear? And depth जो हमको स्ट्रक्चर देखना है वो हमको एकदम बीच में लिखना चाहिए. तो इतनी एक डेप्थ हमें रखनी है. So this is how our depth should be set. बराबर? जैसे एयर अल्ट्रासाउंड में देखा होगा, तो एयरवे का जो स्ट्रक्चर लॉन्जिट्यूडनल व्यू में करेंगे तो वो ओनली 2 सेंटीमीटर में आ जाएगा. और उसका जो लीनियर प्रोब का जो डेप्थ का नॉर्मल जो बाय डिफॉल्ट सेटिंग कितना होता है 6 सेंटीमीटर. तो नीचे की 4 सेंटीमीटर एकदम वेस्ट जा रही है. तो इट इज बेटर टू रिड्यूस द डेप्थ एट दैट व्यू. उस वहाँ पे 3 सेंटीमीटर 4 सेंटीमीटर रख दो, तो हमें जो स्ट्रक्चर दिखता है वो एकदम जूम व्यू में दिखेगा. क्लियर? So these are the basic principles of visualizing our focus. Now, जैसे मैं समझा है कि lungs till 1992 or around 2012, lung ultrasound was never in our even literature. And because of the fact that the lungs are filled with air and ultrasound waves cannot traverse the air, then there is no any point of watching or using focus in our lung. Right? But it was wrong. Even though the lungs are filled with the air, and we will only see the artifacts because of the air. But these artifacts are also very typically or specifically oriented in all normal individuals and in all pathologies. So what are the pathologies? Normal lung, well-aerated lungs and pulmonary edema. Now lung ultrasound कौन सा जो लंग के अंदर जो एयर होते हैं वो एयर से फ्री होती है. उसमें दो पैथोलॉजीज होती है. एक तो आता है हाइपर एरेशन वाली पैथोलॉजीज और हाइपो एरेटिंग पैथोलॉजीज. बराबर. तो हाइपर एरेशन वाली मतलब कौन सी पैथोलॉजी कौन सी हो सकती है? लंग के अंदर ऐसे हो रहा है सीओपीडी और एम्फाइटिस. और हाइपो लो एरेशन वाली पैथोलॉजी कौन सी होती है? ARDS, pulmonary edema, pneumothorax, right? ARDS and consolidation, fibrosis, right? तो जितनी जो low aeration pathologies है, lung ultrasound has a better sensitivity and specificity in diagnosing these low aeration pathologies. And lung ultrasound lacking a good comparable sensitivity and specificity in diagnosing these hyperaerated pathologies. And that's why for COPD and asthma, in exact severity grading, lung ultrasound is not the ideal modality to stand. So in that, for those cases, only CT chase is required. In today's also with so much of evidence, CT chase is far better still than USG. But only advantage of USG is it's bedside, and we can do repeatedly. So we can have actually we can see the trend, what is happening inside the lungs. Here, so this is how the lung ultrasound. Now these are the basic A view, B1 view, B2 view and C view. Right? These are the four profiles that you need to remember for lung ultrasound. Now A is normal pattern of the lungs in well-aerated lungs. Right? So यहाँ पे देखो ये यहाँ पे स्कर्विलिनर प्रोब मैंने रखा है. Okay? यहाँ पे ऐसा रखा है. तो ये व्यू आ रहा है. This is a linear probe और ये consider this a curvilinear probe. Curvilinear probe का इमेज ऐसे बनेगा. ये curvilinear इमेज आएगी. अब यहाँ पे मैंने रखा है तो ये स्किन हो पहला. क्लियर? फिर सॉफ्ट टिश्यू मसल और ये पहली हाइपर इक्वेट लाइन आई. और इसमें मैंने अभी समझाया. फर्स्ट हाइपर इक्वेट लाइन मतलब एयर टिश्यू इंटरफेस. नॉर्मल लंग के अंदर एयर टिश्यू इंटरफेस कहाँ पे आता है? स्किन, सॉफ्ट टिश्यू, मसल, फिर प्लूरल. राइट? तो हमारे लंग जो विसरल प्लूरा होती है और वो हमारी इन दोनों का जो कॉम्प्लेक्स होता है वहाँ दैट इज द एयर टिश्यू जंक्शन. ओके. उसके बियॉन्ड जो लंग है उसके अंदर एयर भरी हुई है. तो दैट फ्रॉम एयर टिश्यू इंटरफेस से जो है हमारे वेव्स विल बी रिफ्लेक्टेड बैक. तो यहाँ से यहाँ का जो स्ट्रक्चर दिखा दिस इज रियल स्ट्रक्चर. बराबर ना. यहाँ पे जो स्किन जो दिख रही है, यहाँ पे स्किन दिख रही है, सॉफ्ट टिश्यू दिख रहा है, मसल दिख रहा है, ये सब रियल स्ट्रक्चर है. और ये प्लूरा आ गई. राइट? एयर टिश्यू इंटरफेस. तो उसके बियॉन्ड जो भी दिख रहा है वो क्या है? पार्टिकल. राइट? वो रियल स्ट्रक्चर नहीं है. वो क्या है एक्चुअली? यहाँ की तो यहाँ तो उसका रिपीटेशन है. राइट? स्किन जो ये एयर तो ये यहाँ रिपीट हुआ, ये रिपीट हुआ, रिपीट हुआ, रिपीट हुआ. तो जो रिवर्बरेशन आर्टिफैक्ट और मिरर आर्टिफैक्ट वो रिपीट हो रहा है. वो एयरवे में भी यहाँ आपने देखा होगा. दिस सेम वे इट इज हैपेंस. राइट? तो इन लंग अल्ट्रासाउंड में भी दिस ए प्रोफाइल मींस दिस इज नॉर्मल ए प्रोफाइल. मतलब whenever we put the probe here, and if we see this profile, means in this profile there is no pathology. It is a normal profile. यहाँ पे रखा ये दिखा. Then it's so there is no any abnormal pathology here at this location. अब यहाँ पे रखा तो ये आया. So now what? Now okay.
So these are the different parts. It's a humidifier. But this is what? Not a saline.
Intact gag reflex.
This tube.
The patient is intact gag reflex. Posterior water touch the patient will comes. So
Here covers only 50% of the laser.
intact gag reflex.
And same how we attach first. Every patient you have to the newer one humidifier, this 540 ones.
respiratory rate and it's a nasal interface. Okay? So initial setting we have to switch on the machine.
So this interval to decide the size of the air.
Select
Screen number is what? So manage two things. One is oxygenation, second is ventilation. Both are equally important to manage and to prevent
any injury to hand, right? Ask the patient to hold elbow. Again, put the apex of the put this under the hand, this over here, and this like this. So this will support the hand like this, okay? The hand. Distal part would be elevated. So the swelling will reduce, the blood loss will reduce, right? नीचे में part ने again you are supposed to tie it over here. And the same thing you can do over here. You can also tuck it if you don't have. Okay, you can see.
Normally a safety pin, I think micropin will also work for a while.
Okay, so if you tuck it, it will be very secure. Okay, this is how you can do it. Very simple. So I think
everybody recollects ma'am's presentation. There's something called effacement. Effacement is the taking up of the cervix. The cervix, because the cervix is a structure by itself, right? The uterus. Cervix has to merge with the uterus. That's called the lower uterine segment. Merging is effacement. For the first time, you'll find that the effacement, it becomes pain-free sometimes. It's very thin, but it's still closed. In a multi, we usually occur simultaneously, may even occur later. So that's the difference. So the first one, all of you should feel is a long closed cervix. Closed, uneffaced, not taken. Okay, that is okay.
Cervix, कौन feel करेगा? So here the patient is now about to deliver. What we require is fabrics which are involved.
This what you can see is a long tubular structure, right? That's the entire step. First one is a closed,
dripping,
uneffaced.
Then give local anesthesia at the time. Crowning. Now what is crowning? I will show you what is crowning.
It's open.
What do you come on this side?
So
As the uterus is contracting and mother is pushing, gradually there is a descent of the fetal head, and when it is at pelvic floor, it is rotation is taking place. Internal rotation is taking place. See, previously sagittal suture was in oblique diameter and now it has come to interposterior diameter, and now hyperlighted has reached up to the outlet. Now it is not receding, so this is the time. So when the head comes out, you have to support the head like this. On one side like this, so two fingers like this,
we can use this
and one hand along with it.
you can start like So the decision for cesarean has been taken. Yes, start.
First,
Be careful, don't cut your hands. Up to the symphysis, go to the symphysis. Go up to here. Full thickness cut over there.
So you are able.
Uterus भी cut हो गया. Be careful, don't cut the baby. यहाँ तक cut होने तो baby नहीं निकलेगा. Readjust your this thing. It should be in a pen holding fashion. तो हाथ से भी आ जाएगा. You can just निकाल लो इसको. दोनों जन निकाल लो. हाथ से थोड़ा सा stretch करो.
Is the baby visible?
Yes.
You need some suction?
See, this part should happen.
Keep speaking as you go through the layers.
ये गाड़ी आ गया, reputation कर दिया.
It's okay. It's okay. It's okay.
Try to hold the head or the try to hold the यहाँ पर see, now you will get the space. It's not till the symphysis, okay? Just protect the bladder. And you will help, okay? You will retract the abdominal layers.
Maybe 20.
Yes. चलो अभी आगे करना पड़ेगा ना. तो आगे ले लो. This is one. Take this. Take another after this one. Take the scissors. बीवी दे दो. Now margins को पकड़ लो. इससे मेरे आगे जाने से. हाँ, प्रेस करना.
हाथ तो हमको भी
बीवी छोटी लगाने के लिए इन्हें छोटी लगाने के लिए
Next to ready.
Get ready. Next to continuation. We are ready now. Okay, next week. Next week.
Train. Okay. So it's absolutely alright to stay calm.
We have 4 minutes.
Chalo.
If you stand till here, you just stabilize the abdomen. बस उससे नीचे bladder. Okay, take on this.
CPR is going on. Yeah.
You can put this inside. Yes. This full thickness चले जाओ, ऊपर में चले जाओ. Full thickness में जाओ. Be careful with the thickness. Don't cut the uterus also in one. Uterus should be in another. यहाँ तक full thickness आ जाओ. Don't put up noise if you want.
Uterus cut off.
This with this hand and this with this hand. हो गया? तो अभी ये सब रख दो और हाथ से बाहर. सब रख दो. Keep this. हाथ से बाहर. Yes. इसको रख दो. Instrument रख दो.
Stretch and open.
Yes.
Yes. Very
And
good.
baby.
Scoop your hands inside. Yes. Yes. Very good.
Very good.
So this is a big baby, right? Yeah.
Next step is the cord clamping. अभी क्या करना तो? अभी क्या करना है? Hemostasis.
Where is the baby?
Right? So it seems as if the fundus of the uterus has become, that is more important than a suprapubic bulge because it's come down, right? And below, a fresh gush of blood and what we call as permanent lengthening of the cord or apparent lengthening of the cord. How do we confirm it? Mammoth said, push down the fundus, cord seems to descend. But when you release it, it will not go back. Right? Then and only then, in the meantime, we have given oxytocin, right? When do we clamp the cord?
Delayed.
Always delayed cord clamping unless and until the baby is in obvious distress. Right? So we have waited to see signs of placental separation, right? We've done a delayed cord clamping, we have given oxytocin, now the delivery of the placenta. Ushali ko dikhayenge? Chalo, aa dekho. Placental delivery. Steps. We know that the placenta is separated. Now we have to deliver the placenta. Kahin se?
Better way.
Better way. Watch what she is doing. The cord is always clamped between 3 clamps. Two towards the baby, one towards the mother, cut in between. Then she.
That you will apply, right? Now this is L Prakash. Take. Sorry. Sir, you also please.
Yes, ma'am. So this is a FATS method, okay, for anterior shoulder dislocation. We have to relocate or we have to reduce. So what we will do, we will gently abduct, and while we have to oscillate also, okay. We will oscillate also when we reach the deltoid up to the 90-degree abduction or above the 90-degree abduction, we will do external rotation, okay, and right
After the clunk, you have to do the internal. So all internal rotations are to be done after the clunk. है ना, उसके पहले आप करेंगे तो there are high chances कि there is a fracture. ठीक है, तो internal rotation तभी करना when we are sure that it is inside the glenoid cavity. अच्छा, इसमें ऐसा है कि if you have understood what we have discussed in the theory part of lecture, if you have understood what is happening, तो आपको यही लगेगा कि आप नाम कुछ भी दे दीजिए, ठीक है. Ultimately you are doing the same thing in all the methods, right? जो कॉकर्स था पहले उसमें जैसे ये है, इसमें हमने पेशेंट का हाथ ऐसे लिया हुआ, this is fast. तो पेशेंट का हाथ ऐसे लिया है, somebody is stabilizing. What we are doing is we are doing.
मतलब पीटी के 4 ग्रेड्स हैं, तो उसमें ग्रेड 1 मतलब एपिप्रोटीज और यूरोला दोनों दिखे. फिर 2 की तो मॉडिफाइड मतलब दिया है, उसमें ग्रेड 0 भी, जिसमें पूरा और ग्रेड अच्छे से ओपन हो जाएगा, मतलब मोर देन 4 फिंगर्स हैं अगर स्कोप पहले वो ये ऑब्स्ट्रक्ट करेगी, ये वो चीज़ है कभी कभी थोड़ा ही है इसको नेक मतलब वी कैन यूज इट टू फर्स्ट और इसको मैं ट्यूब रेलरोड करते हैं आप कोई भी एनालिसिस थोड़ा एडिट होता है तो इस डिराइव रेडियो के बिना के भी शेप बनाता है तो ऑन पेशेंट को एबिलिटी फॉर एग्जांपल जो उसके 55 मिनट लग सकता है एक जो पेशेंट once everything is ready
So now this is the uterus. Put a vertical incision on the uterus. यहाँ से छोटा तो बेबी नहीं निकलेगा ना. Okay, put inside. बेबी आ गया है. सब कुछ रख दो, हाथ से फाड़ दो. That is the amnition. Okay, ये देखो इसको निकालना. Now scoop out the baby's head. ये जो भी सामने आता है. ये बटक scoop out. ये तो बटक भी ले सकते हो. Whatever is feasible. जो दिख रहा है. ये दिख रहा है जैसे ले लो कोई बात नहीं. Slide your inside. Scoop out जैसे करते हैं. Take 2 arteries. निकाल. Now you can hold it, grasp it and take it out. You can also help. I actually baby here.
Yeah.
You can clamp the cord.
Baby tray.
Ready to do? Take green armitages. These are the green armitages. You can rest of
Placenta.
ऐसे करके from uterus. The margins of the uterus. Yes. You read वाला uterus.
Placenta.
हाँ. ऐसे 2-3 करके. हाँ वैसे
शाबाश. Anesthesia वाले.
Leave it here. Green armitages ले लो. Hemostasis container and pack it. This one here.
young
patient is revived, we will take cesarean. Patient is not revived, we will take packing.
So if patient is revived, then we will go for surgery.
Next kit.
So
So don't keep finger and head in between. 1 and 2. 1, 10.
Full thickness, yeah. Go down, give a bold cut.
1. And again.
अभी वो ले लो, retractor to help you. Take one more. Give a bold cut. You hold the retractor in one hand. Go up to the symphysis through each other. Full thickness करो. Okay, uterus has come now. Incision on the uterus. Yes. करो. हाँ ऊपर से. ये मसल है. इंस्ट्रूमेंट सारे रख दो. बेबी निकालो, स्कूप आउट करो.
थोड़ा स्पेस में लेट करो, अंदर को दोनों हाथ से स्कूप आउट.
यस. क्लैंपिंग क्लैंप करो. सीजर ले लो कोई. Caesar. Hand over the baby. Should be there or the bladder should be empty, whatever you do, right? What do we need to assess? Whether she's in labor, whether the contractions have started, right? What is the severity of contractions and the relationship of the baby to the mother. The lie, the presentation. For that, a quick assessment is on observation that you find a distended abdomen, right? Your hand placed at the pubic symphysis will tell you that when it comes down, if this is the umbilicus, right? And sorry, your hand placed at the xiphystrata, right? So, if this is the umbilicus, this is 24 weeks, 28, 32, 36, 40. So, quick assessment, yes, 32 weeks, flanks look full, she's a full-term pregnancy or preterm. Then, what is there inside in relationship? So, the quick fundal grip, what do I feel, right? Do I feel a broad, soft, irregular mass? Or do I feel a hard mass? Everybody should do that. Broad, soft, irregular, breach, hands come down, right? On one side, uniform curvature, other side, knob-like structures. And the hands come down further, straight off second pelvic rib. In an emergency, what do I feel? I feel a hard globular mass that has to be the head. Longitudinal line, cephalic presentation established. On the side of the back, the fetal heart sound will be auscultated. Imaginary spino-umbilical line, right? Approximately, the anterior shoulder would be approximately medial 1/3 and lateral 2/3 of the spino-umbilical. So please come, do that. Everybody should do that.
Now you palpate half will divide. Baby लाओ, baby लाओ.
उसका बेबी बार-बार चोरी हो जाता है. चोरी कर देता है. You should be able to palpate, see, and see the difference because uterine contractions, if the patient is in labor, about to deliver, will last. You'll be able to feel the difference. At the height of uterine contraction, you cannot indent it with the finger. Uterus cannot be. That means it's a nice strong contraction, right? Lasting for around 45 seconds, 1 minute. When she's about to deliver, 1.5 minutes तक भी last कर सकते हैं, right? That means you have to be prepared for delivery.
This is the
everybody should.
This is the pelvis side.
So first you have assessed the funnel height, right? And taken for understood that it's full-term pregnancy. Then funnel grip.
Should be on the right side.
Preferably one-handed or two-handed, whichever way you are comfortable in. Emergency one-handed. Feel. What do you feel? Broad and soft. Broad and soft and irregular, right? And then bring both hands down rapidly in the emergency, just bringing them down, slide them down. On one side is a uniform curvature. One side you feel there is a gap in between, knob leg structures. That means back means east side occiput, east side fetal heart, right? And then straight away second pelvic grip, patient's foot, feet, turning towards the patient's feet. Or second pelvic grip, you have to turn. You cannot face the patient's head. Yes. Right? What do you feel? You feel a hard bundle structure? That's it. So once this is established, you know it's a baby head which is going to deliver, not the reach. And Oscar in the feeding parts. And everybody should do it. Palpation. These are called Leopold's maneuvers. When in an absolute hurry, no time, straight second pelvic grip.
Okay. First you could.
सब omit कर दो. Second pelvic grip पे जाओ, fetal heart सुनो, back पे. अगर बहुत जल्दी है, लगता है बेबी डिलीवरी करने वाली है, क्या चीज के लिए प्रिपेयर रहना है? The hard lumbar structure, right? So that's the head. And the amount of head which actually, and won't be the emergency, how much of the head can be felt also gives an idea of how deep it is into the pelvis.
Okay, so those are two different things. Right? You can even use this in humerus shaft, something like this. Okay, if you are using it in humerus shaft fracture, you are supposed to mold it in such a way that the inner half is a little bit shorter and the lower half is a little bit. Okay, that is for tibia, lower limb, simply. Now, this was about plate. Now we'll go on use
cardboards and
yeah, you can obviously use cardboard. You can use newspaper, wooden stick. You can use even you can even use this towel, right? Just put the towel over here. If you have nothing, then just put the towel over here. Put a ruler between the leg, okay, a foot long ruler, and at least you can. Right, so just make a triangle out of it. Okay, you can easily make a triangle. Once you have made a triangle, there are two ways to put it. Okay, so first way is just put the apex over the towards the equilateral head. Okay, pull it over here. Put this end, one of the ends, over the shoulder towards the back of the patient. Okay, then this end, by then the patient is supposed to hold its hand. Okay, this is mainly used for humerus fractures, right? So once you have done this, you can just tie it off at the back. Make sure your knot is not on the cervical spine, right? After you have put this, you can just arrange it.
High flow nasal cannula. Okay, so see, there are basic things I'll tell you and we'll just clarify. One is oxygenation. One is oxygenation, one is ventilation. This is high flow oxygenation. Okay, devices for oxygen quickly we'll go through. Cannula, space mask, NRDM, venturi. Okay, NIV, which are NIVs? BiPAP and CPAP, okay, and invasive ventilator. Okay, airway you'll learn obviously about intubation and tracheostomy there. And this one, over the oxygenation, I think less than the NIV or you can say ventilator. Okay, what are the indications for HF and C? Anyone? Where we? So all age group we can cover all according to the parameters given set, but the indication for. Okay, pneumonia you can early respiratory failure, type early, okay, not exactly, type 1 respiratory failure, that is hypoxia.
Contraction goes off and goes back in. Comes out a little more, goes back in. Comes out a little more. And then this way. Yes.
So one hand should be here as a support, and other hand should be here, like this.
For sure. एक चेयर है कि आंसर लियो एक चेयर you need to be on that side आ साइड ऊपर आ साइड ऊपर so that
बेबी को छोटी करके
support यदि crowning बाकी चाहिए see internal rotation
Yes, ma'am.
there is an internal rotation now the crowning will take place and I support it like this very well like this and your hand now everything either on this side or like this little bit push the head down so that sudden extension is prevented.
So one hand will be on the perineum using whatever, either we have the you can use a towel, you can use a pad, if not just your hand on the perineum and gently, not even pushing the head upwards, just keeping it here, right? Other hand is on the fetal head. So as a upar se ye do mimic the contraction. As the baby's head delivers, this is called the Ridgen's maneuver, right? And as the baby, so it will be a gradual process, very gradual process of extension till the entire head comes out. Once the entire head comes out, do not be in a hurry to deliver the shoulders immediately. You have to wait for restitution, that means untwisting जो होता है ना, अंदर जब बेबी का हेड एंटर करता है, ऐसे करके हेड एंटर कर रहा है, ठीक है, और फिर इंटरनल रोटेशन होता है ना, इंटरनल रोटेशन हुआ है तो वो अनट्विस्ट तो होना पड़ेगा, और फिर जब शोल्डर्स रोटेट कर रहे हैं इंटरनली तो एक्सटर्नल रोटेशन होगा. Once that is complete, you know shoulders are ready to deliver. Then the holding the baby's head right between your hands, depress for the anterior shoulder and raise for the posterior shoulder. These are the things emergency physicians have to remember. Head delivery, their maneuver to prevent sudden extension. Then if you apply an episiotomy, that has to be given at crowning. At crowning, not earlier, because the thinned out perineum will be best, not just easier, less blood loss and finer incision. Then once the head is delivered, anterior shoulder depression, posterior shoulder raise it, and then the rest of the delivery baby delivers. Once the baby is out, nowadays we place the baby on the mother's abdomen. So वापस रख दो this baby.
Yes, baby is likely to have bradycardia, fetal distress. So immediately you have to clamp the cord, give it to the pediatrician. If the baby is fine, mother has got some other problem, fever or something, and then she has come to trauma, baby is all right, then you clamp the cord after 1 to 3 minutes. So
the needle? No. With pushing the guide simultaneously. Now once it has been there, needle is out. प्रोसीजर नहीं आता. Pulsation. 3 fingers. Like medially. Yes. Now 3 fingers are there. You insert in the middle. First go into subcutaneous. Okay. Now with negative aspiration towards the hips lateral. Don't remove this. 45-degree angle to the skin. Now go in. Yes. Insert the guide wire.
Yes, perfect.
Nothing. Wings only? Yes. Remove the needle with control of guide wire. Once you remove the needle, hold it with the gauze piece. Remove the needle. Then yes, then dilator. And remove it.
રિમેમ્બર આ જે છે એ ઓલવેઝ આઉટવર્ડ હોય સપ્લે ઇવેન્ટમાં ડાઉનવર્ડ્સ હોય અને અહીંયા ઇનવર્ડ્સ હોય.
Inject inside.
So the guide wire
Maximum pulsation towards the intellectual needle.
Different for guide wire placement or not, you have to decide that first. Yes, you, did you go there?
Yeah, we do not have that.
You did not have that. There was here. So the company is different. No? So now guide wire okay, left hand here, right hand needle removal. Okay, right hand આવી જાય બહાર એટલે પકડી એને અહીંયાની સાઈડ આ હાથથી યુઝ કરી શકે પહેલા એકલા જ કરવાનું નહીં
with needle. If it is punctured, it will come.
They really did a fantastic job. It was a DIY.
It is what Indian setup is famous for, jugaad. So, yes.
Anything else? बाकियों ने भी कुछ तो किया है, बहुत मेहनत की है, कुछ all from procedure only, focus वाले सब बाहर है.
सर वैसी मशीन का स्विच बंद करना पड़ेगा, मैं सच बोल रही हूँ.
चार्जिंग बंद कर दो, चार्जिंग.
नहीं मैम बैटरी बैकअप है, वो सब कर दे.
स्विच बंद करना पड़ेगा.
So some negative comments, somewhere we should improve. It's most welcome because it's for the first time we are doing it. But of course all the faculties are well talented. मेरे लिए इतना problem तो कभी नहीं था. Still अगर कुछ है, we are here to listen and maybe next time we can take care of it. I think
पर कुछ सेशंस में ज़्यादा टाइम, for example, हाईवे है, तो there are a lot of things to do hands on. 15-20 minutes में वो करनी है. थोड़ा 30 minutes more time.
anything.
Next time हम
Next.
3 दिन का conference रखेंगे.
Problem is the faculty has to be available for 3 days.
Yes please. So please stay available for us.
But
ये अच्छा कि सब लोग सब प्रोसीजर में एक्सपोजर
मतलब of course our target was more of first year who gets a head start that they have joined recently, and honestly being an EM since 10 years I have never got such opportunity where at one place we get all these things to learn. So we just targeted that at least they need to know the basics. Later on they should not be feeling difficulty कि अरे आप करवाने के लिए चाहिए. So that part we just wanted to remove. But of course I agree. Most of my team also tells us the same that time को ओछो है. But somewhere the lecture versus we had to manage. But let's see. Maybe next time 2 days.
So practically all the procedures in the emergency settings have been covered. So that is the best part.
Focus team. Okay. I still have our procedure teams. Sir जी आप लोग के साइड से all okay? tomorrow we still have to come 8 o'clock in the morning. Again there will be a registration. There will be breakfast. 9 o'clock sharp we will be starting inauguration. Same as today, almost by 9:10 we will start. And then we will start our lectures at 9:30 sharp.
Just a heads up, tomorrow's event will be held at the red building that we saw when we had our breakfast. जो लाल building है campus में, वहाँ पे होगा ABCPH.
So it's Amrita Patel, opposite to our registration.
Yes.
So you might not have to walk so much tomorrow. All our faculties one by one who have really supported us for this conference and for this workshop. Starting from the focus faculties, Dr. Archana ma'am. I would like to call Sanjay Shah sir to please participate. Dr. Jaimin, can you collect the memento on behalf of Dr. Sridhar? Dr. Harshil Mehta. Ma'am, can you please felicitate Dr. Harshil Mehta? Dr. Mihir Pandya. Dr. Yazar Madan. Harsha ma'am, could you please felicitate this? Could you still wait for 2 more? Hey, senior madam. Vaibhav ma'am. Thank you so much. Dr. Sangeeta Pandey. We'll see you. Dr. Mihir Pandya. Shruti ma'am. Thank you ma'am. Now I would like to call Sapna ma'am.
Madam,
Dr. Prachi Pillai ma'am. Dr. Mohit Tolani. Sundaram sir. Thank you, ma'am. I would like to call Hemlata Kamath ma'am to please felicitate Sanket bhai. Ma'am, could you please stay for some time? Dr. Om Shukla.
Nirali ma'am. Thank you, ma'am. I would like to call Mehul ma'am. Please come to felicitate Dr. Bhumika ma'am. Dr. Jyoti ma'am. Thank you, ma'am. So, those who have not received any नहीं okay. सामने पैसे तो okay. Those who have not received, they are basically involved in the tomorrow's program as well. So we will be giving it in the conference. That's the reason. There is no unjustification. इनको ही क्यों दिया, उनको क्यों नहीं दिया? बंदा नहीं मर से. But a vote of thanks, of course, will be coming from Dr. Janki. I would just share my experience that, of course, I did it like we as a department, we did it for the first time. And there was an immense amount of support from all the faculties. If I get stuck at any point, I just have to call one person and they say, obviously, yes, thai ja se, chinta nahi kar. That goes to even my ICU team, my anesthesia team, my surgery team, ortho team, and none other than my ER team, who are always there. मैं हूँ ना हूँ चल ही रहा. Thanks to the EM faculties who were always here from our department as well as from the state, who has really supported us. They were there and they never backed out, saying it क्या करेगा ये बंदा. But thanks to delegates who have also supported, who thought that okay, this will be worth doing it. So I really thank you. Lastly, I would call Alpa ma'am to felicitate Birwa ma'am.
Emergency medicine teaches you strange skills like eating under 90 seconds, recognizing footsteps of panic, explaining calmly for the 5th time why the patient who has come in later is being seen first. It is not easy, it is not glamorous, but because in that thin, fragile space between chaos and consequences, somebody has to stand there and decide. And for better or worse, that someone is us. To conclude, I congratulate all for gathering here, discussing, debating, learning, unlearning, and maybe quietly questioning a few things that we thought we were sure about. Respected dignitaries, distinguished guests, esteemed faculty, and dear participants, proposing a vote of thanks for this session or hands-on workshop for emergency procedures and focus is not going to be easy. I might even break down.
We are deeply thankful to our expert faculty and resource persons whose guidance, practical insights and dedication have made this workshop truly valuable. The hands-on learning and real-time demonstrations have undoubtedly enhanced our understanding and confidence in managing emergency situations effectively. I would also like to extend heartfelt gratitude to all the participants for their enthusiastic involvement and active engagement which brought life to this workshop. Our sincere appreciation goes to the organizing team, consultants, residents, volunteers and technical support staff whose meticulous efforts ensured smooth conduction of this program. Thank you everyone who helped us in making this workshop a reality. Your help made a difference. Thank you all.
Thanks everybody for giving us this support. Actually, we are a very young department. Okay, only 2 years into emergency medicine. All of us are very fresh. But Dr. KU, Dr. Rishabh and Dr. Harsh, they are the pillars. And Dr. Janki, who has joined us recently, but I would really like to felicitate her. All of you who have done the perimortem CS procedure workshop, she has developed those mannequins by herself, without any help. I mean, it was the real effect. I mean, I had the passion of developing a skill lab which is going to be cost effective, and she has proved it. I mean, I could do it and she has done it. So I am very happy that we could do this, and all of you who have done on those mannequins today will definitely support that. You got a real feel of doing a perimortem CS. So I think she is the one who's really put her wholehearted effort for that, and I am here just to say that to her because the whole team in fact has supported her. And this whole effort of conducting this state level workshop, Dr. KU, who initially thought of doing it, he had the guts to go ahead with it, and the whole team who stood by him, I mean, they really need a great applause.
Now I would like to call Abhishek Bhai to say some good things.
Thank you. First of all, congratulations Kemkon team. So I am here to have some announcement. I already announced in our focus workshop, but as we all know that Karamsat is a well-developed team of who are trained in doing focus. So we do focus workshop on regular basis, and we have done already 4 focus workshops which are of 2 days. So we are planning that focus workshop in June, and after that workshop we are announcing a thoracic ultrasound fellowship of 6 months. It will be a hybrid workshop and it will be very useful to everybody, and it will be cover airway, lungs, heart, the advanced echo which is useful in emergency and our day-to-day practice, and some of the diaphragm. So these are the things we are going to cover, and it will be structured course, it will be supervised course, it will be some kind of weekly online lectures with demonstration of the clips by the delegates, and it will be scrutinized by our well-trained examiners and faculties in the field of critical care or emergency medicine. Our team has already the faculty and examiner of the fellowship of ultrasound, and we will be we have developed that course, and it will be useful for everybody, for pulmonologists, intensivists, emergency physician, and whoever in the practice who wants to do something good to the patients in emergency conditions. So this is one announcement we are going to announce in June or July, and for that please follow ISSM Karamsat Facebook page. So, thanks.
Please grab the opportunity. It's really important because now it's the focus. Darshan Bhai wants to say some good words.
So thank you KU and Harsh Bhai, Rishabh Bhai and everyone for conducting such a nice workshop. You know, the procedure workshop that I have never thought of, these kind of procedures can also be taught in the workshop. Okay, so it was wonderful planning and execution from their side. Just one last announcement that we are also conducting some of the workshops in the field of artificial intelligence, basically AI in the healthcare. And some of the faculties, HODs of Neeta madam, Harsha Makwana madam, they have already, Archana madam, they have already attended our workshop, and it will be quite useful. We will be sharing the links of this AI based workshop that is especially useful in the healthcare setup, with the model development, with the coding, and with the different types of image generation. These kind of workshops we are conducting on a regular basis. Also for the research, we are conducting the workshop where you can publish your publication or your article in a very smooth manner. Data collection and data analysis, that is also possible with the help of AI. So we are conducting the workshop, so we'll be sharing the links in the faculty groups.
So finally we conclude. Thank you so much for all your support.